مش عارفة عشان نظبط الشعر.
لا ده هم يشوفوها عيب.
طيب بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good morning everybody. We are delighted to start the first session in this third scientific annual meeting. The first speaker is Prof. Yasir Ahmed Al-Ghunaimi. He's a professor of cardiothoracic surgery and Al-Imam Abdul Rahman bin Faisal, Kingdom of Saudi Arabia, is going to talk about CT-RAT and attractive minimally invasive CABG. Dr. Yasir, you can take the lead.
احسبوا لي الوقت ده منهم بقى. شكله اشتغل اهو. شكرا. السلام عليكم. Thank you so much, Professor Ali, and thank you for the organizing committee and for the chairman for inviting me to always be here among my colleagues and my family in my second home. Today, inshallah, I will talk about a new technique for minimally invasive cardiac surgery, which is called the TCRAT. TCRAT stands for Total Coronary Revascularization through Left Anterior Thoracotomy. I will explain it step by step, and this is a very important technique. Inshallah, we'll try to apply very soon at Nabd al-Hayam. For this one, the problem with the minimally invasive techniques, usually there is a fear from the incision because usually it is a small incision. You need specific instruments. These instruments could be long instruments. They're always a difficult. The problem are regarding the access and setup. Even the technique of coronary anastomosis itself, sometimes it will be very different from this point of view. To apply this technique, you need choreography between the whole members of the team, meaning the surgeon, the perfusionist, the anesthesia, the nurses, and scrub nurses. You cannot do this by one-man show. It needs complete coordination between the teams. When we start this program, we started with the patient selection because there are specific criteria and stand-up infrastructures for this technique regarding patient selection. Imaging is very important, especially echo and CT scan. The cannulation strategy is different. Such cases, myocardial protection and the pain management are also very important technique. When we started, if you'd like to start this program, you have to start with the patient selection. Better to start with the patient without extensive neurological problems, patients who are not very obese, and you select the procedures like 2 grafts instead of starting for revascularization. And then once you progress in your program, you can apply more grafting techniques and you can select more complicated patients for this. Imaging is very, very important in this technique. The most important part is doing a pre-operative CT scan. So now I will explain step by step how to start a TCRAT as a new methodology for starting minimally invasive for revascularization coronary artery bypass grafting. CT scan is very important to make sure the patient has no peripheral vascular disease, because our technique in cannulation always depends on the peripheral cannulation. Like for example, you can see this patient have extensive vascular disease. With this extensive vascular disease, you cannot proceed with the cannulation technique because we start this technique by femoral cannulation. So starting by doing a proper CT scan and select and measure the degree of calcification is very important in this case. Technique of cannulation is very important. We do either open cannulation through the femoral region or the femoral triangle, or we start by percutaneous technique, and this depends on the expertise of the team. For cannulation, we do either open technique or percutaneous. We have to do imaging. If you have the facility to do closure device, you have to do it, to utilize it percutaneous. Imaging is very, very important. In our center, we use ProGlide, which is a percutaneous device occlusion technique. By this device, we don't need to expose or open on the femoral arteries, but we insert the cannula femoral artery and the femoral vein through the percutaneous technique. You have to utilize the ultrasound, and this ultrasound is very important because the ultrasound will give you guide exactly where is the common femoral artery in there and femoral vein. And this is extremely important because you don't need to have a hematoma by blind exposure or blind puncture of the femoral artery. Once you insert the cannulas, you are now ready for the next step of the operation. Also, transesophageal echo is very important for insertion of the venous cannula. The echocardiographer should give you the bicaval view. For this bicaval view, you insert the venous cannula under direct echocardiography guidance into the femoral, into the superior and the inferior vena cava, because one of the most important steps in this operation is to have a good venous drainage and the complete evacuation of the heart. Of course, once you do decannulation and you finish the operation, the decannulation is very easy. For the venous cannula, we don't need except pressure, percutaneous pressure, but for the arterial cannula, it is better to use a ProGlide, or if you are having option of open exposure, you can close it by surgical technique. And now we start the first step of the operation is by putting the patient in the supine position. For our anesthesia team, we need double lumen endotracheal tube or endobronchial blocker, because using this operation, we have to collapse the left lung completely. And then we determine and do landmarks to reach for the fourth intercostal space. Our technique starts for opening incision 6 to 8 centimeters in the fourth intercostal space. This incision, this is exactly where we locate this incision. In males, it is easy in males to apply the technique because the breast is not in your face. However, for females, it is difficult, so you have to utilize the submammary technique or submammary incision to have a good exposure and avoid the breast, which will be, even in female with a huge breast, you can apply this technique. And you can notice here the heart in your face. It is not far away after this exposure. And then the operation started by doing the femoral cannulation. This is the first step. And then we start by doing a small incision, transverse incision 4 to 6 centimeters in the fourth intercostal space. This is a muscle splitting incision. We don't cut any muscles, because if we cut muscles by this technique, the patient will have a lot of pain in the post-operative period. So we divide the muscle and do incision exactly in the fourth intercostal space. This incision is very important because once you have a good exposure and a good dissection, you will find yourself exactly in the front of the heart. And then we need two specific instruments for harvesting the internal mammary artery. We can utilize the same instruments, but in this case, you need long tip cautery, long applicator for application of the clips, and long the beaky clamps for holding the mammary artery. And then we start the incision. After we expose, we come to the internal mammary artery, because this is the most difficult step in the operation itself. By exposing the internal mammary artery in the fourth intercostal space, once we reach for this internal mammary artery, we divide the artery, and then we start harvesting the internal mammary artery. As you can see here, under direct vision, you start distally and you go proximally as much as you can until you get the internal mammary artery from its origin from the left subclavian artery. And it is not difficult, it is easy, and you can use it either full pedicled mammary artery harvesting or skeletonized mammary artery harvesting. You divide the internal mammary artery distally, and then with a specific chest retractor, it is called the mammary retractor. You have 3 steps to reach for the mammary. First, you have to identify the mammary, and then you divide the mammary, and then you expose the mammary until you reach for the internal mammary artery until its origin from the subclavian vein. It is not a difficult operation, it is not a difficult step, it is easy, but it needs some patience, especially at the beginning of the program, because most of our surgeons now, they are used to use the full sternotomy, and they are feeling very comfortably in doing harvesting of the internal mammary artery by the open technique. But you have to teach yourself how to expose the internal mammary artery. And then, if you notice here, the heart comes to your face. That's why comes with a value of cannulation at the beginning. If the proximal segment is difficult to harvest, you start the cardiopulmonary bypass, and you see now the heart is getting away from your exposure, and the cannulation will give you a better view for harvesting the mammary from its origin until you reach for the landmark of the subclavian vein. And you see with this technique you can reach for, of course, you apply babaverine as you use usually in our technique, because the mammary now is fully harvested, and then by opening in the fourth intercostal space, the length of the internal mammary artery is very, very long, and you can reach for any space you like. And then you start opening the pericardium. Opening the pericardium here, you have to open the pericardium generously until you expose the aorta, because exposure of the aorta is very important for the other steps of the operation. And then one of the most important steps for our technique is doing aortic cross clamping. Aortic cross clamping, we apply the cross clamp from the left second intercostal space. This is called a sheathwood clamp, and you apply this clamp through this space until you reach the aorta. طبعا هنا very important to have the problem. This is to have a good exposure, you need 3 tapes. First tape, you have to insert the tape around the aorta, and another tape around the left pulmonary veins, and the third tape around the inferior vena cava. How we do this? This is how you apply the tape around the ascending aorta from the same incision. Of course, it is very small incision. You cannot insert your hand inside. So we're utilizing long instruments until you do a dissection between the aorta and the pulmonary artery. And after you do the dissection for this pulmonary artery and the aorta separate from each other, you utilize either right angle clamp or C-shaped clamp to pass around the aorta and apply the tape. And this is very, very important step in the whole operation because it gives you a good control of the aorta and gives you a better access because you can pull on the aorta and bring it in your face. And this is very, very important step on the operation. So applying the tape around the aorta itself, it is not a difficult step, but it is really important, very important step in this operation. And then sometimes if you have a heart in your face, you just drain the heart by going on full bypass. You see here, once you apply the cross clamp, the heart will be away from your face, and then you have a good access to the aorta itself. And then we insert the cardioplegia cannula and apply the cross clamp, and then you inject the cardioplegia until you have a good cardiac arrest for this operation. Then we start the second most important step, which is applying tape around the inferior pulmonary veins. Here we shifted the heart, we flipped the heart upwards, and then we apply a clamp around the left superior and the left inferior pulmonary veins. And by application of this tape, you will have a good manipulation. You have a good exposure with using these tapes to reach for the obtuse marginal arteries and diagonal arteries, as well as the right coronary or BDA. Once you finish putting this tape around the aorta, you tilt the heart to the opposite side, and then you have a good exposure from this is the inferior vena cava side, and then you just flip the heart. You see here, the heart is completely arrested. It is not like mid-cap, because in mid-cap, the heart is beating, comes to your face, and you cannot do these maneuvers. So you apply another tape around the inferior vena cava. By application of these three tapes around the aorta, inferior vena cava, and pulmonary veins, you can move the heart in any direction you want, and you can do full revascularization, 3 or 4 grafts, as if you are opening the sternum completely. And this is the main difference between this technique and the other mid-cap techniques. And then the easiest step in this operation will be doing the distal anastomosis. Here you can see doing the obtuse marginal artery, although it was intramyocardial, but it was very easy to harvest the vein and anastomose the vein in the obtuse marginal artery. Very easy, using regular instruments, no specific instruments, and then you do the distals, the whole distals, including obtuse marginal, BDA, lima to LD, and then you remove the cross clamp to start the proximal anastomosis. Proximal anastomosis should be done on partial cross clamp. We remove the aortic clamp and we apply a C clamp around the aorta, and doing the proximals on the cardiopulmonary bypass with partial cross clamp. You see here, you're doing from this exposure, you can see here 2 openings in the aorta for 2 veins, and already the memory is done and harvested and anastomosed. And this will be the final result with the small incision. You can compare this incision with the huge or sternotomy incisions. Of course, there are some problems with myocardial protection, which is the usual and the standard fashion. Pain control is an important issue in these operations, especially for BCA, local anesthesia, or paravertebral block. There are too many benefits from this technique, including full revascularization, because the other mid-cap technique, they can do only single graft, which is lima to LD or maximum 2 grafts. By this technique, we can do full revascularization, 3, 4, 5 grafts, according to the patient's need. The incision is small, and this has a cosmetic impact, especially in female And now all the patients, I can say this, within 5 years from now, no patient will ask you to open his sternum, and he will ask for minimally invasive cardiac surgery. So the patient satisfaction is very important. Also, it has a very important effect on the patient's recovery and the returning back to normal, and most importantly, avoiding the problems of mediastinitis. Quick return to normal life, to work, and then you have economic impact because we be able to send the patients back to their work as soon as we can. The blood loss is much lower, post-operative complications are less, and also when the program advances, you can apply this technique for high-risk patients, especially obese patients or patients with multiple comorbidities. However, there are limitations like technical expertise, patient selection at the beginning, the learning curve, and at the beginning of your technique, it will take longer time, but once you gain more experience, the time for this operation will be equal to the time of the standard coronary artery bypass surgery. Thank you.
Thank you, Prof. Yasser, for this concise, precise, informative, interesting talk. Although he exceeded the time, but intentionally I didn't disturb him, so that it's a very interesting topic. I'm sure that maybe some of us for the first time heard about this, so he gave the chance for him 3 minutes more. It's not a problem. We will leave the discussion till the end of the session after the last speaker. Thank you. Now I will give the microphone to Dr. Ahmed, to Mohammed Saadi to introduce the second speaker.
شكرا بروف بطرفي. طبعا the next speaker is Dr. طيب بافضل. His talk on primary BCI challenges. طبعا الدكتور طيب بافضل هو صاحب العرش، بالتالي معروف للجميع. هو الدايركتور اوف نبض الحياة كاردياك سنتر المكلا. تفضل دكتور.
Okay, thank you very much, Mr. Chairperson, for this introduction. Actually, I will start with my talk about the primary BCI, what is actual challenging of this procedure. So I will start my presentation with 2 cases. This is the first one. This is a male patient, age 75 years old, presented with acute coronary syndrome, anterolateral STEMI. Actually, the patient is hypertensive, has orthopedic problem, so had multiple limitations for cardiac surgery. This patient cannot move freely. This is what the presentation, what was seen in that's what see in as you see in this patient has multiple limitations. This is after primary BCI. It has a distal left main with the total LAD, LCX at the lesion. After a primary BCI, that's what we see in this patient. LAD, and the LAD is patent. This is the second case, is a female patient, 43 years old, hypertensive, presented with acute coronary syndrome, STEMI. That's what we see in the left system. As you see, there is no left main with a total LAD and LCX. This patient was referred for CABG. So In general, ischemic heart disease and the cardiovascular disease is the single most common cause of the death, and is frequently is increased. And this with the recent published data that the cardiovascular disease is the most common cause of the death in all over the world. The relative incidence of the acute coronary syndrome is increasing in European countries, about 34 to 140 for even 10,000 population per year, and this most patient has MI die before receiving a medical attention, mostly from arrhythmias and ventricular fibrillation. So the patient is presented with a chest pain, suggested acute coronary syndrome, and the ECG evidence of acute STEMI and evidence of new left bundle or right bundle are candidate for reperfusion either with primary BCI or fibrinolytic therapy. So these modes, it improves outcome of patient with acute STEMI of this patient. طيب الفايبرينوليتيك الفايبرينوليتيك ثيرابي اللي هو ستريبتوكاينيز has a severe limitation. أول حاجة it has multiple contraindication. 50 of patient ربع هذا المرضى thrombolysis will not occur, وجزء كبير من هؤلاء المرضى يحصل re-occlusion of the infarct related artery. While in the primary BCI أول حاجة receive high TIMI 3 flow, it doesn't carry a risk of intracranial hemorrhage and associated with improved outcome. زي ما شايفين في الجدول دي it has severe limitations or contraindications of the fibrinolytic therapy, either absolute or relative contraindication. As we see, it has multiple limitations and contraindications for fibrinolytic therapy. لكن if we summarize إنه البيشنت متى ياخذ الفايبرينوليتيك ثيرابي أو ممكن يتحول على البرايمري BCI. لو كان البرزنتيشن حق المريض within 3 hours better can be primary BCI or fibrinolytic therapy. After that, the primary BCI is preferred. أو إذا كان ال BCI is available, it will be better solution. إذا كنت شاكك في ال BCI, إذا كنت شاكك في الdiagnosis, إذا كان high risk patient, the patient will be presented with heart failure or KLIB 3 or higher, better for primary BCI. طيب نحن ليش نعالج البرايم بي سي اي ونكون الامور سريعه وستيبس باي ستيب سريعه؟ ليه؟ لانه في مقوله minutes mean muscle، يعني كل تاخير او كل دقيقه تاخير في البرايمري بي سي اي جزء من الهارت muscle will be die. As we see in this slide, on the left side, this is the infarcted artery and the area around it هي الاريا اوف ischemia. لما ندخل في الاربع ساعات الثانيه الاريا اوف انفاركشن تزيد، وبالتالي الاريا اوف ischemia تبدا تقل لغايه ما يبدا لما نقول الاريا اوف انفاركشن معناها اريا اوف نكروزيس، معناها انه ديد ماسل. ذاتس طيب وات اباوت الجايد لاينز؟ ايش تقول؟ الجايد لاينز تقول انه في اول 3 ساعات يمكن تقدر تعطي الفايبرينوليتيك ثيرابي او البرايمري بي سي اي، لكن بعد ال3 ساعات عندنا هنا الفايبرينوليتيك ثيرابي بيبدا يقل، والبرايمري بي سي اي الانسيدنس حقه او الانديكيشنز يبدا يزيد لغايه كم؟ لغايه 48 ساعه. بعد ال 48 ساعه there is no benefit for revascularization either for primary BCI or reperfusion or fibrinolytic therapy. طيب في ايتمز نبغى نفهم بها بس على البي سي اي. في حاجه اسمها ريسكيو بي سي اي. يعني ايش الريسكيو بي سي اي؟ يعني انه المريض اخذ ستريبتوكاينيز وفايبرونوليتيك ثيرابي وحصل فيلير في الريسبونس، فبالتالي المريض يتحول على البرايمري بي سي اي. في حاجه اسمها روتين بي سي اي افتر فايبرونوليتيك ثيرابي، هذا يكون within 2 hours الى 24 ساعه. في حاجه اسمها فارماكو انفيزيف استراتيجي، نعطي فايبرونوليتيك ثيرابي وبعد كده المريض يتحول الى بي سي اي كابابل سنتر within 24 hours either successful fibrinolytic therapy or not successful fibrinolytic therapy. It is the routine. طيب في حاجه مهمه بالنسبه للتروبونين. I mentioned في الحاله لان نشوف حالات كثيره انه الدكاتره عندنا في المستشفيات وفي الطوارئ يعتمد على CKMB وما يعتمد على تروبونين. الآن الجايد لاينز الأخيرة there is no role for CKMB for diagnosis of acute coronary syndrome. Please troponin, and the most sensitive is the high sensitive cardiac troponin. It's not available in our community, in our hospitals، لكن إذا كان متوفر حيكون أفضل بكثير. طيب إمتى ألجأ إلى الأذر بايوماركرز زي CKMB والمايوسين والكوبتين؟ إذا كان الهاي سنسيتيف تروبونين أو التروبونين it's not available in our community أو our hospitals. طيب ننسى في حاجة مهمة جدا، إنه التروبونين يطلع في حاجات كثيرة. it's had multiple disease طلع التروبونين without acute coronary syndrome. ضمنها انه يحصل حاجه عندي coronary spasm، الكوروناري امبوليزم، النون اثيروسكليروتيك، الكوروناري ارتي دايسكشن، البراديكارديا، الهايبوتنشن. الحاجه الثانيه كمان انه في other causes الهارت فيلير، المايوكاردايتس، الكارديومايوباثي، التاكتسوبو، هذه كلها diseases بتطلع التروبونين without انه يطلع acute coronary syndrome or myocardial infarction. This is other disease, especially chronic kidney disease patients اللي يكون عندهم مشاكل في الكلى ويبدا يحصل لهم increase في التروبونين. طيب what about the recommendation انه الريبرفيوجن انه يكون افضل في الاستيمي، سواء كان انه البرايمري بي سي اي is recommended. البرايمري بي سي اي لو كان اقل من 120 دقيقه better، this is class 1 indication. الريسكيو بي سي اي is recommended after failed fibrinolytic therapy. تمام. وانه البيشنت after 48 hours of symptoms there is no benefit or class 3 indication for primary BCI. وانه transfer to BCI capable center is recommended in all patients after fibrinolytic therapy. طيب what's happened in our country؟ أول حاجة البرايمري بي سي اي has little patients. ليه؟ most common cause is a financial problem. Most of our patients enter CCU and receives thrombolytic therapy or streptokinase mostly. CCU ممكن يدخل المريض CCU not receiving الفايبرونيليتيك therapy because of lack of diagnosis, not available, contraindications of fibrinolytic therapy. انه بعض الشارين او الاخصائيين خايف انه يعطي ثرومبوليتيك ثيرابي because of the other problem. فليحصل انه المريض يدخل على conservative treatment في السي سي يو وبعد كده يعمل diagnostic coronary angiography later on to determine الاناتومي. وبالتالي الانسيدنس اوف ذا هارت فيلير تزيد والانسيدنس اوف مورتاليتي والموربيديتي بتزيد بيسايد الكوست على المريض انه دخل في الاي سي سي يو وبعد كده عمل كوروناري انجيوغرافي، كل هذه كوست على المريض. طيب لو جينا الى الاحصائيات الموجوده عندنا في مركز نبض الحياه، هذه الاحصائيه حقنا في 2024 عملنا ما يقارب 1312 حاله بي سي اي. البرايمري بي سي اي منهم كانوا كم؟ حوالي 115 حاله، يعني البرسنتج لا تتجاوز 11%. وانا اتكلم على مركز الفاسيلتي موجوده، عندي بعض جهات الداعمه سواء كان مؤسسات خيريه، عندي برنامج يغطي بعض الحالات، فهذه الانسيدنس الموجوده فتعتبر قليله جدا في البرايمري بي سي اي ان اور سنتر. دي احصائيات عام 2023 هنلاقي ان احنا عملنا حوالي 1540 حاله بي سي اي، منهم 117 فقط حاله برايمري بي سي اي، والانسيدنس حوالي 13%. It's low incidence for primary BCI in our center. طيب one of most solutions او ممكن نستخدمها هي الفارماكو انفيزيف، اللي هو نعطي روتين ادمنستريشن اوف ذا ثرومبوليتيك ثيرابي في اي مكان في اي مستشفى، وبعد كده يتحول المريض من المستشفى اللي هو فيها الى بي سي اي كابابل سنتر. هذه في ريجسترز وستاديز معموله على الفارماكو انفيزيف ستادي، والتيبل ذا يوضح لي انه على مدى السنين او الابحاث اللي اتعملت انه الفارماكو انفيزيف از بيتر، فارماكو انفيزيف از بيتر، ايرلي از بيتر. فبالتالي الفارماكو انفيزيف انه الروتين المريض ياخذ ستريبتوكاينيز في اي مستشفى وبعد كده في خلال ساعتين الى 24 ساعه يتحول الى بي سي اي كابابل سنتر. I think it's one of most common solution of this problem. فبالتالي الجايد لاينز لخصوا انه الديلي في الاستمي يا اما يكون انه المريض من جهه ما يجي له السيمتوم لغايه ما يظهر الى الفيرست ميديكال كونتاكت الى ما يتشخص الى ما ياخذ الريبرفيوجن. فعندي يا اما في بيشنت ديلي او عندي سيستم ديلي. فهذه ممكن نحلها بطريقه انه البيشنت ديلي نزود الببليك اديوكيشن، الهوسبيتال ديلي نزود الكونتينوس ميديكال اديوكيشن فور اول ميديكال ستاف، الفاينانشال سبورت share other institutes, other charities for this problem. So I will conclude, it's acute coronary syndrome is increasing all over the world. A pattern of reperfusion either with fibrinolytic therapy or primary BCI is mandatory over these cases. The pharmacoinvasive therapy is one of the advisable methods in reperfusion. Increase the awareness of the disease and the therapy and the continuous medical education and the shared problem is common or mandatory for this problem. Thank you very much.
شكرا جزيلا. Thank you very much, Dr. طيب فاضل, for this nice presentation. I will introduce Prof. Dr. Abdullah bin Laban for the next presentation.
I will introduce Professor Ali Al-Masoudi from Riyadh. He is professor in the College of Medicine, Al Faisal University, consultant interventional cardiology and heart transplant, heart center, King Faisal Specialist Hospital and Research Center. He will speak about how to increase the success, the rate of your CTO cases. Dr. Ali, you hear me?
نعم, I can hear you. What about, can you hear me too?
You can start.
صوتي واضح؟
ممتاز.
طيب, السلام عليكم ورحمة الله وبركاته. أولاً أشكر الزملاء الأعزاء الأفاضل على على الدعوة للمشاركة في هذا المؤتمر المتميز، وأخص بالشكر زميلنا الدكتور الطيب فضل والأستاذ الفاضل الشيخ محمد باشعيب والزملاء الآخرين والشير بيرسونز as well. وأنا الحقيقة يعني كما ذكر الدكتور ياسر غنيمي أنا أشعر يعني I feel home لما أكون في أي مشاركة في اليمن وخصوصا في المكلا أو أي مكان آخر في اليمن، وأتمنى التوفيق وأن تتيسر الفرص القادمة نكون معكم in person إن شاء الله. حتى لا أطيل عليكم أنا I was asked to present a topic about chronic total occlusion, and as you know chronic total occlusion is the last frontier of interventional cardiology. This is one of the most complex anatomies that may be faced by interventional cardiologists in the cath lab. My talk will be focused on how to make this procedure more successful. First, I would like to just revise with you the definition of chronic total occlusion. Simply, chronic total occlusion, if there is complete occlusion of major coronary arteries with TIMI zero flow of more than 3 months. And I'd like to remind you of the differences between the acute occlusion and chronic occlusion. Acute occlusion usually occluded by soft plaque, more contents of cholesterol, lots of macrophages, loose fibrous tissues, while the old occlusion is characterized by hard plaque, fibrocalcifications, and more of collagen and calcium deposits on the occlusion site that make it much more complicated and complex for intervention. There is recent interest in chronic total occlusions in the literature, as you can review if you do literature review from 2005 till 2009, only 237 publications related to CTOs. And then this number was doubled from 2010 till 16. And more recently, more than 2,300 publications from over 4 years, from 2016 and 20. So there is much more interest in chronic total occlusion in interventional cardiology, and this is for multiple reasons. First, the prevalence of CTO is not uncommon. In fact, 18% of patients with coronary artery disease will present with chronic total occlusion. Those who comes post CABG to the cardiac catheterization, 50% of them have chronic total occlusion. Even acute coronary syndrome, in fact, ST elevation MI, 10% of them, they will present with chronic total occlusion. And patients with CTO usually have more comorbidities, there are more prevalence of diabetes, peripheral vascular disease, heart failure, and impaired ejection fraction. So this is very high risk subset of coronary artery disease patients. And the mortality is increasing with the presence of CTO as being described on multiple registries. And when the patient has CTO, the management strategy changes because of the complexity surrounds the intervention. So most of the patients, or many patients, when they were found to have CTOs and diagnostic angiogram, they will be offered only medical therapy, as you can see in this study and Barry registries. If the patient with CTO has collateral, does this mean he has enough supply to deal with ischemia? In fact, no. As you can see here, and multiple studies, that collaterals will never be enough to meet the demand of the myocardium, and most of these patients will continue to have residual ischemia. In fact, good collaterals equals 90% coronary stenosis. So what are the benefits and challenges related to CTO? Of course, successful BCI to CTO will improve angina symptoms, will normalize functional tests. It may help to improve ejection fraction, avoid the need of more invasive intervention like bypass surgery, and hence reduce cardiac mortality, while there are lots of challenges surround the intervention to CTO. There is a low success rate if you compare it to non-CTO lesions. It requires a lot of expertise, lots of instruments, and the risk of complication definitely is higher in CTO interventions. Multiple registries has shown significant improvement in quality of life for those who underwent successful BCI to CTOs, improve physical activities, less anginal frequency, improve quality of life, and more treatment satisfaction. There is no clear randomized clinical trial to support mortality benefit of CTO intervention, but there are registries has shown that successful BCI to CTOs is associated with improved survival on long term. And we know from before, complete revascularization is better. So if the patient has CTOs of one of the major epicardial arteries, for sure, revascularization of that territory will be associated with better outcome. So with regard of current available data that we have for CTO BCI, we know there are consistent improvement in quality of life, consistent reduction of needing bypass surgery, but there are conflict results with regard of improvement of ejection fraction and mortality. So we don't have clear evidence if we are talking about randomized clinical trials. So if you wanna stick to appropriate use criteria, it's appropriate to attempt CTO intervention to symptomatic patients and patients with high risk non-invasive tests, like they have high territory of ischemia based on nuclear scan or PET scan, but we are not certain if of the benefit if the patient has minimal symptoms or asymptomatic. And just to highlight very important point related to CTO intervention, the CTO volume is associated with increased success. So centers with higher volume of CTO cases, the chance of success is higher. So the recommendation is to establish centers of excellence. Not everybody should attempt this complex subset of patients, because these patients require specific sub instruments, require lots of experience. So diluting the cases definitely will have negative impact on patients' outcome. So what are the prerequisites for CTO intervention? Patient should have symptoms. We should have evidence of reversible ischemia. And if there are useful collaterals, then the chance of success definitely is higher. The toolbox of CTO PCI are sheath, guide wires, guide catheters, micro catheters, snares, and externalization wires, and complication management set. If we don't have these, probably it's not wise or safe to attempt complex CTO. With regard of procedural planning, good diagnostic angiogram is critical. Diagnostic angiogram will facilitate selection of crossing strategy, and it will help to decide the tools that are needed to be used in that procedure. We should use low magnification and avoid panning to have appropriate understanding of anatomy and reduce the radiation hazard. We should be generous with using intracoronary nitroglycerin, of course, if the blood pressure allows for better visualization of the coronary anatomy. And we should avoid ad hoc CTO procedure. Classically, we spend 10 to 20 minutes to review the study and different projections and take it frame by frame to understand the appropriate anatomy and the length of the lesion, amount of calcification, tortuosity, the description of proximal and distal cap, and the quality of the distal vessel. All these are important. Vascular axis of paramount importance. Usually we use 2 axes for dual injections and for evaluation of distal bed of the CTO. And most of the time we prefer 7 sheet over 6 French sheet. And we should utilize the complexity scores. The most commonly used scoring system is JCTO scores, where it evaluate the entry shape, is it tapered or blunt, the amount of calcification, occlusion length, is it less than or more than 20 millimeters, and if there is how the degree of tortuosities, and the chance of re-entry or retry lesion. If the patient has been tried before, that's increased the risk. As you can see in the image on the left side, this, for example, occlusion is long, there is blunt proximal cap, but the distal vessel quality is fine. There are multiple algorithms being introduced to the practice. The first one was hybrid algorithm that was introduced to 2012 by American groups of CTO club, and the recommendation was to use double injection and to assist the proximal cap, distal target, and the collaterals. If the patient has good collaterals, there is no ambiguous proximal cap, we should attempt antegrade. If the patient has ambiguous proximal cap or good intervention collaterals, we may start from the beginning retrograde. In fact, my personal approach to try antegrade on most of the cases and switch between strategies. So we start antegrade, we start wire escalation, then if failed, dissection re-entry. If failed, we move into retrograde approach. Asian Pacific CTO Club has introduced another algorithm in 2017, and the algorithm highlighted the importance of use of cardiac CT scan and intravascular ultrasound to guide the CTO intervention. And they introduced other technique like parallel wiring, which is very useful technique for CTO intervention, and limited entry subintimal tracking. So this is one of the examples where IVUS is very important to identify the proximal cap, where you can use IVUS to the side branch and then try to localize the proximal cap and study its characteristic, and this guided to successful BCI. IVUS is helpful too to guide re-entry if the wire goes subintimal in the at the occlusion site. It will help definitely in to identify intra-plaque space, extra plaque, and extra plaque at bifurcation, as you can see in these images. OCT is very important, but there are limitations associated with the OCT. OCT require a significant amount of contrast, and it's not difficult to do it again and again because it's more time consuming if you compare it to IVUS. However, it's helpful, as you can see, total occlusion of significant OM branch. OCT help to identify the location of the proximal cap of that occlusion, and that was associated with the successful recanalization. Live CT scan has been introduced recently as a tool that can definitely of value to plan CTO intervention and study the amount of calcification and the length of the CTO and tortuosity. Euro CTO Club has proposed another algorithm that is very useful as well, and if you can see, most of the algorithms consider switching between strategies. We have commonly 4 strategies: 2 antegrade and 2 retrograde, wire escalation and dissection re-entry, and we should be flexible moving from technique to another, and this is associated with increased success rate. Let me take you through one of the cases that we have done a few weeks back. You can see this patient has CTO occlusion of the LAD, and he has tight CERC occlusion. In fact, we offered this patient CABG, but the patient adamantly refused CABG. So the plan was to fix his CERC, because you can see this type A lesion, significant area of jeopardy, and the LAD need long time. So this procedure was staged. So we fixed his, first we calculated his GCTO score. His GCTO score was 2 to 3 because the proximal cap entry is blunt. There is no calcification, so he has 0 with regard to calcification. Occlusion is more than 20 millimeters at 1 point. There is no so 0. It was retried, so it's 2 to 3 scores. So it is difficult to very difficult case. So we fixed CERC with 3.0 by 18 stent. Then retrograde injection was done to assess the distal vessel and collaterals. We started as usually with antegrade wire escalation with microcatheter support. Unfortunately, the initial attempt with wire escalation didn't help, so I moved to parallel wire technique. Again, this did not help. As you can see from retrograde, still these wires are subintimals. Multiple trials tried, but still the wires are subintimal, as you can see. So we attempted retrograde approach, but unfortunately there was no good well-developed collaterals. So we switched again to wire de-escalation and escalation antegradely, and then eventually we managed to go into the true lumen distally. That was supported by injection of contrast, and then the procedure was concluded with 2 long stent with very good result. But these cases need patience, need understanding of the anatomy and flexibility of moving from technique to another. This is another case just to highlight the importance of dual injection. You can see RC injection shows you how complex is the LAD, and it shows you multiple CTOs. So if you don't have the dual injection, you will not be able to identify the two occlusion sites, which can mislead you if you just go with ipsilateral injection. So we started antigradely. It was challenging to cross, so we take micro catheter to support the Gaia second, then parallel wire, and then we went retrograde because we failed antigradely to go into the lumen. Retrograde wire nicely crossed to the true lumen. Then the procedure was concluded with a very good result, as you can see. So again and again, hybrid algorithm is very useful to increase the success rate of CTOs. And then I'd like to highlight an important point, which is when to stop and how to stop. So we should not just keep trying till the patient, have bad consequences of bad intervention. If the complication arise, we should stop. If the likelihood of success is very low, we should stop the procedure time. If it's exceeded 3 hours, or the contrast volume exceeded more than 3 times the estimated GFR, we should stop the procedure. And if the radiation exceeded 5 grays, the recommendation is to stop the procedure. How to stop? You can make the first trial, as introduction for a second successful procedure. And we have many cases where we tried in the beginning and created subintimal space through extra plaque ballooning, and when they come after 4 to 6 weeks, you see much easier micro channels that leads to successful BCI. What are the possible complications related to CTOs? Patient may develop vessel perforation. The intervention to collaterals may cause collateral destruction and ischemia, renal failure, and radiation injury. All are possible complications. As you can see in this case, there is distal perforation. You should be able to know how to deal with this with using coils or fat pad to occlude the small branches. Thrombus formation is another common complication, so we should keep ACT more than 300, and we should be very careful with regard to radiation hazard for the staff, for the patient, for the operator as well. And I recommend having algorithm for dealing with certain complications that may arise with CTO intervention. For example, hypotension. If the hypotension related to the target vessel or the donor vessel, or it's not coronary related. All these are important, and we should have algorithm how to identify the possible complication and how to deal with it. If there is ST changes or ongoing ischemia, again, is it related to the target vessel or donor vessel? And then we should deal with the complication accordingly. We should be able to retrieve equipment if it's entrapped in the CTOs, and we should be familiar with snaring, cut wire, or trapped wire into the plaque. So, have you given your patient the best shot? Parking on CTO is not the only option that we offer our patients. We have aggressive medical therapy, we have lifestyle modification. They definitely will have positive impact on the patient outcome, and we should address these for patients with coronary artery disease. There are certain cases we should never be attempt, like those with CTO that feeds only scars, or CTO where the distal vessel is not visualized either antigradely or retrogradely, and when the chance success is less than 50% and the risk of serious complication is high, probably you should not attempt these cases. So for successful CTO BCI, you need to treat symptomatic patients with high risk non-invasive testing. We should have contemporary techniques that help, and we should evaluate and study patients very well to have successful procedures. And I would like to conclude by highlighting the main indication of CTO BCI. and put more emphasis on meticulous pre-procedural planning and utilization of contemporary technique, and have systematic approach for complication. And thank you very much.
Thank you, Prof. Ali. We will open the ground for discussion. Any question for Prof. Ali before he leave us?
Prof. Ali,
Thank
thank you very much for elegant lecture. Regarding unfortunately radiation, as you know, the CTO sometimes you spend a lot of time and you failed. What about the safety for the patient?
Yeah, of course. I mean, patient safety is priority. So we should have, as I mentioned, we should have limitation. The radiation should not exceed 5 grays per case, and the time, fluoro time, should not exceed 3 hours as well. So we should weigh the benefit and harms, and we should be, of course, put more emphasis on patient safety and staff safety as well. Using low radiation dose is very important too, and fluoro time, fluoro rate, all these are important to minimize radiation exposure and radiation hazard. Otherwise, the risk of skin burning on the patient is high. The risk of like brain tumor, cataract, all being reported for the operator, CTO operators.
Any question?
Thank you so much, Professor Ali, for this excellent demonstration of the CTOs. My simple question, when you decide to use Ambilla or ECMO for CTOs?
Shukran, Dr. Yad. Very, very important question, in fact. If the patient has LV dysfunction, what we usually do, we evaluate them for the need of assist devices. The assist devices that we have in the cath lab, either intra-aortic balloon pump or Impella. Generally speaking, we prefer Impella because it gives more stable, more hemodynamic support. If the patient has severe LV dysfunction, we use ahead of time, before we start the procedure, Impella. If we are not sure, we pass the catheter to the LV and measure LVEDB. If the LVEDB is elevated, we use the assist devices, either Impella or intra-aortic balloon pump. If the LVEDB is low or the patient has good LV function, we don't use assist devices unless we're dealing with the left main. Then we tend to use assist devices as well.
Thank you, Prof. Ali. Now I will introduce Abdul Malik for introduce the next speaker.
شكرا جزيلا دكتور. المتحدث القادم بيكون من سوريا البروف ماجد عثمان، adult consultant cardiac surgery. راح يتكلم عن الاورتيك روت سيرجري. ولتفضل.
مش الحال؟ ما عم يشتغل. ما عم يشتغل. اوكي. السلام عليكم، صباح الخير. ما شاء الله متعة، الرؤية من هون متعة. شكرا لكم. كان الأستاذ الدكتور عبد الناصر منيباري طلب مني إني أتكلم باللغة العربية، فشو بتحبوا، عربي، إنجليزي، فرنسي، روسي؟ كله بيمشي. يعني بدي ارجع لسيبويه شوي. وسيبويه عندما قال في تعريف حتى واعراب حتى: اموت وفي نفسي شيء من حتى. بصراحه الاورتيك روت سيرجري اند اورتيك سيرجري يمكن انه عندي نفس الانطباع، انه اموت وفي نفسي شيء من حتى. بدي غير شوي الموضوع اليوم، بدي ادخل على الحاله الجزيئيه. الحاله الجزيئيه بالاورتيك روت سيرجري which is يعني بصراحه غير مفهومه حاليا، ولسه في عندنا مجال واسع كبير للانتقال للمرحله اللي بعد منها. بس بغير. تعال يا ابني، يا ابني تعال. سلايد. اوكي. وطي الصوت شوي، وطي الصوت. فالانسيدنس اوف ثوراسيك اورتيك انيوريزم اند ديزيز، طبعا كلياتنا بنعرف، وهي ارقام مكتوبه بكل الكتب، هي من 9 ل 16 بال100,000 برير، وهذا احصاء موجود بالكتب بشكل واضح ومو بحاجه للاعاده. المهم بالحديث هي ان الاورتيك روت از ا فانكشنال انتيتي، يعني الكل يتعرف على ان الابهر الصاعد والقوس الابهريه والابهر الصدري النازل او البطني هي عباره عن تيوبز. نو، it's a functional entity which means انه هي مشتركه بالعمليه بالداره الهيموديناميكيه بالسيستول وبالديستول. فاذا هي بدنا نتعرف على كلمتين، انه هي functional entity. الدياجرام اللي عم نشوفه امامنا كلياتنا درسناه لما كنا طلاب طب سنه ثانيه، مر على الكل بدون استثناء لما كنا طلاب طب سنه ثانيه. ايه، ولليوم غير واضح، ولليوم لسه فيه مشاكل، لانه لحد الان هلا لو سالت طالب طب سنه سادسه بس اشرح لي هذا بحكيك ما بعرف. السلايد كثير مهم. هذا السلايد السبب الاساسي نحن يعني وفي انفسكم افلا تبصرون. هون التغيرات النسيجيه او تغيرات مساحات الابهر الصاعد والحلقه الابهريه والدسام الابهري، عم ارجع على كلمه فانكشنال انتيتي، هي تغيرات بسيطه جدا، لانه لما بنحكي بالاورتيك روت سيرفيس اريا بالسيستول عم تزداد فقط، بالدياستول عم تزداد فقط 3%. فاذا التغيرات هي بسيطه جدا. الكوميشنال اريا انكريز 4% والانيولس اريا انكريز 3% والساينوتابيلر جانكشن انكريز اباوت 2%. فاذا التغيرات اللي عم نحكي فيها بهالداره هي تغيرات بسيطه، ونحن عايشين عليها، على هالتغيرات البسيطه التي لا تتجاوز باعظمها 4%. فاذا هي فانكشنال انتيتي. طبعا هذا بنعرفه كلياتنا. نحن الكلاسيكال اتيتيود هي ديجنريتيف ونون مارفان انيلو اورتيك اكتيزيا اور مارفان، وحاليا هي نفس الحكي ديجنريتيف وفاميلي ومارفان بيشنتس. سؤال واضح. which kind of procedure should be performed؟ لانه الاسئله كثيره. السؤال الاهم what should be avoided؟ انه ما نساوي بكل بالاورتيك روت سيرجري ان كانت دايسكشن او انيوريزم. في عندنا مشاكل ثلاثه، عندنا هي في بروكسيمال تير، في ديستال تير، وفوسلمن. شلون بدنا نصلح الفوسلمن؟ شلون بدنا نصلح البروكسيمال تير والديستال تير؟ Any successful repair combines many factors: restitution of blood flow, the reinsertion of supraortic branch tree, technical simplification of surgical procedure, assurance of neurocognitive function, and the protection of abdominal viscera and adequate surveillance of multi-modular steps. الجزء المهم نحن حافظنا وهدفنا من العمل الجراحي هي العضلة القلبية كعضو نبيل، لكن العضو النبيل والأهم هو الدماغ وكيف نحافظ عليه. فإذا هي كمان مشكلة ثانية ويجب أن تطرح ويجب أن نتكلم عنها بالتفصيل، وخاصة أنه بغرف العمليات المسؤولين عن جهاز القلب الصنعي اللي هن عم نساوي التروية هن بده يكونوا على علم بما تقوم به وهن adequate about the procedure. فعندنا مشكلتين بالسيريبرال بروتكشن، هي انه بدنا نحاول الهاي ميتابوليك ريت، بدنا ننزل الميتابوليك ريت، وبدنا نحافظ على الجليكوجين. فاذا في عندنا مشكله ستورج اوف اكسجين وعندنا مشكله الميتابوليك ريت. المعادله معروفه وموجوده بكل الكتب، هي موضوع السيريبرال ميتابوليزم اوكسجين كونسامبشن. الهدف مثل ما عم احكي هي سيريبرال ميتابوليك ديماند must be suppressed، والconsumption of oxygen and glucose انه مستمر maintained. المعادله كمان معروفه ومأخوذه من الكتب، ما في شيء غريب، هي موضوع اللي cerebral blood supply موجوده. هلا بدنا ندخل بالحديث. من خلال انه الاورتا نورمال اورتا الدايمتر اباوت 3 سنتيمتر حتى يصل إلى 5.5 سنتيمتر. مجموع العوامل الجينية التي تدخلت في هذا الموضوع حتى يتوسع الأبهر. فإذا نحن من 3.5 ل 4.5 هي which is normal ascending aorta. بعد الأربعة في عندنا عوامل جينية عم تدخل، من 4.5 ل 5 في عوامل ثانية، من 5 ل 5.5 في عوامل ثانية. فإذا لما بناخذ المخطط هذا هو عم يختصر محاضرتي كلها، يعني كلامي كله مختصر في هذا السلايد انه على انه مستوى بدنا نشتغل. الهيستولوجي نفس الشيء، انتما ميديا ادفانتيشيا. وظائف الانتما معروفه، هي فاسكولار فانكشن، ريجوليت فاسكولار فانكشن، والميديا هي is a critical controlling aortic biomechanical function من الالاستيستي للكومبلينس لابيليتي تو ديستانس اند ريكول والتنسل ستيفنس. فاذا عم ارجع اعيد وعم ركز على كلمه انه الاورتا از فانكشنال انتيتي. الادفانتيشيا هي فايبروبلاست اند اديبوسايت والاكستراسيلولر سيل containing collagen, elastin, vasovazora, lymphatic. فهي الاورتيك ادفانتيشيا provide nourishment of the aortic wall, gateway of inflammatory and inflammation, contain abundant stem cells. وانا اعشق هذه الكلمه، وأنا برأيي أن الطب بكامله معتمد على هذه الكلمة ستيم سيلز والعودة إلى الحياة الأولى وهي الستيم سيلز. وحد الآن أنا قناعتي كل الأمراض التي نعالجها علاجها موجود في هذه الكلمة. مخطط توضيحي واضح هذا، ما في شيء. فالسؤال الثاني المطروح انه مقاطع الابهر الاورتا ان كان بالاسندنج اورتا، بالاورتيك ارش، بالثوراسيك ديسندنج اورتا او ابدومينال اورتا، هن كلهم مثل بعضهم؟ نو مختلفين اختلافا كليا، لان الاورتيك سيجمنت ديفرنت ستراكشر اند فانكشن. الاسندنج اورتا whereas the pressure is higher and thickness media is greater, while aortic media became thinner as the aorta descend. The aortic root and ascending aorta are composed of elastic wall, multiple elastic lamina, and distensible proportion of responding blood volume and the pressure. Will extracellular component of descending thoracic aorta differ greatly from those of ascending aorta. الموضوع هو اللي كنا بدنا نحكي فيه واللي جاي أنا أحكي فيه، هو موضوع الجينيتيك. موضوع الجينيتيك the study of biological inherited trial including traits that are influencing the environment. عربيا لحتى تكون الجملة واضحة، الجينات، عندما نتكلم عن الجينات نقول دراسة الصفات المنقولة بيولوجيا، ومن ضمنها الصفات التي تأثر بالبيئة. البيئة باليمن غير البيئة بالسويد، فهي تؤثر جينيا. وحدة الحياة كما هي معروفة هي الجينوم. الجينوم هو the study of genes, of all genes in organism to understand molecular organism. فإذا في عندنا function، في عندنا interaction، في عندنا evolutionary history. سبحان الله، هالسلايد نحن عايشين عليه تماما كلياتنا. الحياة البشرية أو الحيوانية كل ما به روح متوقف على هي DNA replication translation بصير RNA وبصير بروتين، ونحن عايشين على هالمعادلة الصغيرة هي. واليوم بعام 2024 جائزة نوبل أخذت على موضوع ال RNA. نوبل العام الماضي كانت على RNA. فنتكلم عن الطفرة الوراثية. الطفرة الوراثية الدي ان اي عبارة عن حلقة كربونية مرتبطة بالجذر النيتروجيني والجذر السكري، فهي الادونيزين، ثيامين، سيتوزين وجوانين. اي تغيير موروث للمادة الجينية او للعملية التي يحصل بها التغيير، فهذا بنسميه صار في ميوتيشن، تغيرت الطفرة. بالثوراسيك اورتيك انيوريزم الجينيتيك بيزس فور ذا ديزيز في سيلولار ميكانيزم وفي الكلينيكال مانيفستيشن. كيف تتظاهر هذه المشكله؟ التغيير الموروث اللي صار كيف يتظاهر عند الانسان؟ فاذا الميوتيشن that place them at high risk for dissection, silent disease that is notorious by different to detect the diagnosis prior to complication. الجينيتيك سكرينينج وهو 20% of patient report possible family history. تنويه بالنسبة للأطباء القلبية، ليس كل توسعات الأبهر وأمهات دم الأبهر وتسلخات الأبهر هي عائلية، لا عفوا، ليست هي إنه لأنه كل أطباء القلبية كلكم بدون استثناء توسع جذر أبهر ضبوط الضغط، مشكلتك ضغط. لا دكتور، في مشاكل تانية غير الضغط، في مشاكل تانية غير الضغط، لأنه بدون استثناء وعم عمم وأنا واثق من كلامي كلياتكم خافضات ضغط بالأول، أول كلمة خافضات ضغط. هون بس الدياجرام عم يعطينا التوزيع بالنسبة للفاميلي هيستوري وبالنسبة للعوامل الأخرى، لأنه بلش الزمن ينتهي. عندنا 4 طفرات وراثية مسؤولة عن معظم أمهات الدم الموروثة وغير مرتبطة بمتلازمة. غير مرتبطة بمتلازمة مثل مارفان هو متلازمة، هو سيندروم. هدوك الناس الثانيين غير مرتبطين بهالمتلازمة هي، يعني نون سيندروميك. هي ال ACTA2 وهي MYLK وهي MYH11 وهي PRKG1. ال ACTA2 encode smooth muscle cellular specific and action polymerized to form a thin filament of smooth muscle contraction element. Is the most common mutation linked to familial thoracic aneurysm with about 50%، يعني المنقول منها 50% من الصفة الوراثية هي منقولة. ايوه، والاورتيك tissue mutant patient are characterized by protoglycan can accumulate will decrease and disorganize the smooth muscle. فالdisorganization of smooth muscle بالنسبة للميديا وfragmentation of elastic fiber. This evidence suggests widespread of systemic disruption and adaptation to vascular wall stress leading to aneurysm and dissection. Notably, ACTA2 mutant tend to cause aortic dissection without pre-existing aneurysm. لأن كلياتنا بنشوفها في مرضى بيكون عندهم dissection هو ما كان عنده aneurysm سابق، ما كان عنده aneurysm سابق، فهو تعرض بشكل مفاجئ ل dissection. 1/3 of patients of ACTA2 mutation have acute aortic dissection type A at the aortic dimension أقل من 5 سم. لأنه كلياتنا كمان حاطين ببالنا إنه توسع جذر الأبهر أكثر من 5 سم قد يعرض هذا بالميوتيشن اللي نحن عم نحكي عنه، هو أقل من 5 سم وعم يعرض المريض للدايسكشن. The pregnant women with ACTA2 mutant are even high risk of small diameter of dissection. وكلياتنا كجراحين شفناها. امرأة حامل بالشهر السابع aortic dissection مع انه ما كان عندها سوابق. فإذا البيشنت with ACE2A2 mutant are therefore recommended for surgical intervention between 4.5 لل 5 سنتيمتر. العنصر الثاني اللي بدنا نحكي عنه MYLK myosin light chain kinase known as phosphorylate regulating light chain myosin 2 ATPase activity endocytosis stress fiber response influence. اللي بدي احكيه بهالموضوع هذا اللي mutant linked to high risk of dissection. هالرابط هذا الجيني هو مرتبط تماما بالتسلخات الابهر بالاورتيك dissection. ف due to a high risk of dissection diameter اقل من 5 سنتيمتر، كمان وجود هذا العامل يعرض للتسلخات الابهر بقطر ابهري اقل من 5 سم. فاذا suggested surgical intervention between 4.5 لل 5. MYH11 encode smooth muscle myosin heavy chain، كنا عم نحكي light chain هلا heavy chain. Contractile component mutation result dysregulation of smooth muscle contraction which is critical for maintaining aortic wall stability. causes بتسبب 1% من الفاميليال thoracic aneurysm mutation. increase pulse wave velocity, decrease aortic compliance, decrease elasticity in the aorta, leads to dissection. Surgical intervention suggested about 4.5. الأخير هو ال PRKJ1 هو encode the type of depending on protein kinase control smooth muscle contraction and clinical data are limited. هون الدراسة الأخيرة وأكثر ناس درسوا بهذا العنصر هن الروس بالجين الأخير هن الروس. penetrance of dissection مهم كتير إنه 63% منهم ينتقل من الآباء إلى الأبناء. في penetrance كبير. limited data حول الموضوع are encouraged to have prophylactic surgery بال4.5. Therefore, standard guidelines regarding surgical intervention at aortic diameter between 5 and 5.5 هذا كلياتنا متفقين عليه انه لازم يساوي العمليه. لعجل شوي لانه الزمن انتهى. الجينيتيك تيستينج الباست اند ذا فيوتشر. الجينيتيك سكرينينج to identify high risk patient early and receive timely prophylactic surgery. الجينيتيك في عندنا سانجر سيكونسينج وعندنا quantifying RNA signature. وطبعا بالنسبه للبانل whole genome screening the classifying gene into 5 different categories. The RNA signature able to classify thoracic aorta compared to control. عم يعطينا sensitivity 72% و specificity 90% can be utilized as point of care diagnosis. طبعا هي الجمله الاخرانيه كثير مهمه لانه نحن اذا كنا بوسط فعلا ماديا واقتصاديا لما بنساوي هالفحوصات فهي نوع يعني دراسه عوامل الانذار لهذا المرض لمستقبلا. سلايد كثير مهم هذا. هي data demonstrated RNA signature show promise biomarker. دراسه البايوماركر بين الفاميليال والنون فاميليال. التست الاخير اللي عم نحكي عنه طبعا هاي الدراسه موجوده ومن 2012 لل 2019. هذا انه الناس اللي ساووا لنا هالفحوصات واثبتت الكلام السابق فاذا هي بازدياد مستمر. المخطط هذا موجود بكل الكتب حطيته فقط للاستئناس. واخيرا وكلمه اخيره برنسبل بموضوع الاورتيك سيرجري كله keep it simple. keep it simple. كيسينج يعني كيسينج يعني اخر بعد كل هالوجع الراس طلعنا بقبله. keep it simple and smart وتصرف بذكاء. شكرا لكم.
شكرا جزيلا بروف ماجد. نترك النقاش لنهايه الجلسه.
Okay, شكرا. Now we come to the last speaker but not the least, بروفيسور زكي عبد الله الازهر. الاخوه في الكنترول اوكي بعدين. الإخوة في الكنترول أوكي جاهزين؟
I think we're ready. We're live.
As I said, the last speaker but not the least, Professor Zaki Abdullah Zahir is a senior consultant cardiac anesthesia and critical care medicine in Ministry of Health Kingdom Saudi Arabia. He's going to talk about opioid-free cardiac anesthesia. Professor Zaki, do you hear me?
Yes, I do.
Okay, you can start.
Good morning, everyone.
Most welcome.
Okay. Do you see my slides?
Yeah.
Okay, so yes, good morning, everyone. First of all, I would like to thank the organizing committee and the scientific committee for their kind invitation. And I'm so glad to be with you today. And I wish I could make it physically, but as you could see, I'm in the operating room. So we, anesthesiologists, we cannot schedule our time. So we apologize for this. So in the coming 20 minutes, I will talk about a new concepts, and it is it's going to be a future practice, in not only in cardiac anesthesia, but it could be for almost all modalities of anesthesia for different major procedure. And we call it, it's an opioid sparing for cardiac surgery. I have no conflict of interest to disclose. And the outlines of my presentation, why opioid based? Why? Because as you know that in cardiac anesthesia, we depend mainly on opioid. So we call it opioid based cardiac anesthesia. And when I was trained in McMaster, we used to use safentanil, and we used to give mega doses of safentanil. And I was trained all the time using high doses of opioid till later, 2015, I started to realize that there are more of evidence supporting that we need to come down with our opioid doses. So our outlines will be why opioid-based, visibility and safety of low opioid, and visibility and safety of no opioid in cardiac anesthesia, and why not opioid-based cardiac anesthesia. And then I will, in a brief, I will present our multi-modal opioid-free cardiac anesthesia approach in our cardiac surgery center. So if we ask any cardiac anesthesiologist why you like to use opioid in cardiac anesthesia, first of all, it gives very good analgesic. I would call it, rather than analgesia, anti-nociceptions, and we still don't know much about the physiology of cardiac surgery pain and neurohormonal release and how we do control of these. So basically, I will change the term of analgesia to anti-nociception, because analgesia, we give it for pain, and pain is a conscious unpleasant stimulation. So analgesia is not applicable in a sleep patient under anesthetics, but we give our opioid basically to maintain the hemodynamic stabilities, avoiding tachycardia and hypertensions. And this is through blocking the pathway for neuroendocrine hormonal effect of surgical trauma. The second point is the hemodynamic stability, which we considered opioid has more hemodynamic stability. When it comes to opioid without supportive medication, i.e. induction etomidate, most of the patients, they go hypotensive. And there are a very good comparison studies between opioid induction versus lidocaine. Both group, they have propofol and lidocaine versus propofol and fentanyl. The group of opioid, they went hypotensive more and require more of inotropic support. So the concept of hemodynamic stability is a question with the new evidence. In myocardial protection, and that's the third reason we intend to use high doses of opioid. When it comes to the myocardial protection, it is in literature, it's all about animal studies and in vitro, and I haven't seen any clinical evidence supporting that using opioid in a human being will give you a myocardial protection. Opioid started, the high opioid doses in cardiac anesthesia started 55 years ago. And here is this paper was published in 1969 in a New England Journal of Medicine, and it was published from Boston. And this is, they call it the cardiovascular response to large doses of intravenous morphine in men. So what is the story of opioid? This is the story of the beginning of high opioid doses in cardiac surgery. In Boston, they used to have lots of immigrants, illegal immigrants with rheumatic heart disease, presented late to cardiac surgery with pulmonary hypertension and RV failure. And they used to do the practice. They used to do thiopental, succinylcholine, and they maintain patients on halothane and nitrous oxide with muscle relaxation. What they have observed that they have higher mortality intraoperative for those cases. And what they observed in the ICU, those who survive intraoperative, when they shifted them to ICU, the ICU team, they started in morphine infusion at high doses. And they observed that those patients, they survived the post-operative. So the concepts of the high opioid was tried, and as I said, intraoperative, and they used to put a high dose of morphine in IV drip to do induction of anesthetics. It go up to 3 milligram per kg. So the group reported the outcomes of 15 patients, 7 with aortic valve disease and 8 normal controls. And after that, they published this studies, and it get widespread popularity because it provide hemodynamic stability if you compare it to our old medication, which is not used anymore now in our current practice, which is the thiopental and the halothane and nitrous oxide. Okay, this could be one of the first paper to compare high doses of opioid versus low doses of opioid. It's a meta-analysis, the first meta-analysis. So they had 18 studies, almost 1,400 cases. They observed that there is no difference in primary outcomes. So when we use high opioid versus low opioid, no difference in secondary outcomes in ventilation time, in use of vasopressors, post-operative and intraoperative MI, stroke, and hospital length of stay. So at meta-regression, there was no effect of age, gender, of type of opioid use. So this is one of the first evidence supporting that the high dose in cardiac anesthesia is not mandatory. So we could do cardiac anesthesia with low dose opioid. So the option of giving high doses of opioid, it's almost similar outcome. So we don't need to go with this practice. And another study published in anesthesia analgesia, this published from Johns Hopkins, Baltimore. It was published in 2020 when they implemented the ERACS, the Enhanced Recovery After Cardiac Surgery. So they had an error before they started the project versus after they started the project. So they went to assess the association between intraoperative opioid administration and postoperative outcome, comparing high dose of opioid, which is more than 50 milligram morphine sulfate equivalent versus lower than 15 milligram morphine sulfate equivalent, and to investigate an impact further when they do more of restriction of an ultra low of opioid. This is their anesthesia protocol, and that's why we call it the multimodalities, because when we use opioid, when we want to reduce our opioid uses, we need to introduce a different medication, which has a different effect at different pathway and at different receptors. So this is their anesthesia protocol. They use gabapentin, acetaminophen, ketamine, Presidex, and they used to do regional block in form of ultrasound-guided serratus anterior block. And this is their what they observed, that they were able to increase the number of interventions in cardiac surgery, and at the same time they were able to drop their intraoperative opioid consumption over the few months after starting their Iraq's protocol with multimodal analgesia approach. And here are the clinical parameters and outcomes. They're almost similar. There is no much differences. So their conclusion that they were able to mark reduction in intraoperative opioid administration over the course of 9-month study period. There was no negative impact of post-operative outcomes. A further study designed to assess the impact of opioid minimization is recommended. Another study comparing after the implementation of ERACs, so cardiac enhanced recovery program implementation and its effect on opioid administration. That was published in Seminal Thoracic Surgery 2022, and this is their pathway, as you could see in the slide. So they ended with 236 cardiac surgery and 118 per group. What they have observed that they were able to reduce their opioid use at the post-operative day 0 significantly drop. As you can see, the blue is the opioid, the pre-Iraqs, and the yellow is the post-Iraq. So, and you can see that there is significant drop when they implement Iraqs, significant drop by in the first 0 day of surgery by 65%, and post-op day 1 with 60% reduction in opioid consumption. And at the same time, they were able also to achieve better post-operative pain score with the low opioid doses. So they have post-op day 1 better pain score with significant statistic. And here is their clinical outcomes, and I will highlight on the significant finding. They have the post-operative morphine consumption is less, total morphine consumptions as well as a drop. Average pain score is significantly better, and prescribing opioid on discharge is better. Post-operative non-steroidal administration, they used it for the multimodal patients. The most important part, when we reduce an opioid, we will have a significant reduction in post-operative nausea and vomiting, and you can see this could be a very serious complication, which will lead to delay our patient discharge, and patient will stay longer in ICU or in the hospital, where they get prone for more of hospital-acquired infection. So what they conclude that the 79% reduction in perioperative opioid administration, and they have improved their patient pain score while maintaining very excellent outcome. And they want to have a more of a prospective studies or randomized control trial. Another publications, this is the balanced non-opioid general anesthesia with lidocaine with lower post-operative complications compared with balanced opioid general anesthesia. So here we started with no opioid general anesthesia. So gradually I presented the evidence of reduction of opioid. Then now we reach here to almost non-opioid for general balanced anesthesia. And this is here are the inclusion criteria, exclusion criteria, and the primary outcomes and outcomes: post-operative respiratory failure and confusion, incidence of acute kidney injury, death, and length of ICU and hospital stay. Here are their anesthetics management protocol. I will not go in detail through it. This is almost equivocal intraoperative characteristic. What they have found with this, that they were able to conclude that they have a significant reduction in post-operative outcomes, complication outcomes. So they have reduction with significant p-values. They have shorter intubation time in the ICU. They have less non-invasive ventilation for those who get extubated. The opioid group require more of positive or non-invasive positive pressure ventilation, and they require less re-intubation as well, and they have less ARDS, acute respiratory distress syndrome, and they have found that the non-opioid group, they have less confusion. And here are this slide shows the details of this post-operative complication. As I stated, with non-opioid, they did very, very much better with less post-operative complication. And this is their conclusion here. The balanced non-opioid general anesthesia with lidocaine was associated with decreased post-operative complication, including respiratory failure and confusion. Again, because this is a new practice, after these 55 years of practicing using opioid, everybody is little conservative and getting to a solid conclusion. They always recommend to have more of prospective randomized control, could be blinded study, which is going to be very, very challenging to conduct. Here's another studies comparing our in cardiothoracic opioid free anesthesia versus opioid-based anesthesia in patient undergoing cardiovascular and thoracic surgery. Meta-analysis, we have 3 of cardiac surgery and others are thoracic surgery. And here is the 24-hour pain score is in favor of opioid-free, postoperative nausea, vomiting in favor of opioid-free, as you can see in this slide. The 48 hours also morphine consumption is in favor of opioid-free anesthesia. Requirement of inotropic support as well, it is less in opioid-free anesthesia, as you can see here. The non-invasive ventilation as well was less. It was in favor of opioid-free cardiac anesthesia, as well as the length of hospital stay by day is in favor of opioid-free cardiac anesthesia. So this is their conclusion. Opioid-free cardiac anesthesia and cardiovascular surgery was associated with reduction of postoperative nausea, vomiting, inotropic support needed, and non-invasive ventilation when we compare to opioid-based anesthesia. There is a very potential benefit of opioid-free anesthesia and cardiovascular surgery patients. Larger comparative studies are needed. The question now, as we reach after all this evidence, why not opioid? Again, what we try to prove that no opioid is acceptable practice if we compare it to opioid base. Now I will do the vice versa comparison here. So why not opioid? It is opioid, as you know, that it is dose-dependent side effect, and you could you have a long list of side effects of opioid consumption, very disabling for patients and delay post-operative rehabilitation. And most of the evidence now recommend the early mobilization and early returning to physiological life. This opioid high doses will delay, patient will be drowsy with nausea, vomiting, constipation. They will be very, very difficult to mobilize them early, and this will increase the risk of atelectasis and risk of post-operative complication. It has immunomodulation also effect, and it has significant impact on infection and in cancerous pathologies. Possible neurotoxicity is there, and persistent opioid use, the post-operative, and as I'm sure you heard about the opioid crisis in North America and Canada and the United States. Even in the debate, they discussed the fentanyl addiction and fentanyl markets in the United States. and majority of the opioid medical use initially, they may ended with a straight addiction. Opioid could induce hyperalgesia, which most of colleagues, they do not know that opioid is as analgesic, but it could cause hyperalgesia. The cardiac surgeon may notice that patient will still complain of some
Dr.
pain
Zaki,
after
3 minutes left more.
Sure.
You had
Okay.
already exceeded the time, but we'll give you 3 minutes more.
Okay, sure. Then I would go to our experience. This is very important slides to prove the opioid persistent opioid use in 2 studies. They proved there is a 10% of opioid addiction post-cabbage and 8% addiction of opioid addiction post-valve cardiac surgery. This is a very important publication. It was published in the United States, where they expert from cardiac surgery, cardiac anesthesia, critical care, clinical pharmacists. They had a group of experts in North America, where they need to come with recommendation, and they initiate the stewardship of opioid. Stewardship means limitation of using opioid. And here is their first recommendation. As you could see, a strong recommendation. We recommend against the routine use of high-dose opioid anesthesia or analgesia for patient undergoing cardiac surgery with level of evidence B. Same thing, second recommendation, we recommend implementation of perioperative opioid stewardship for patient undergoing cardiac surgery. Strong recommendation with the level of evidence B. Here are the option of non-opioid medication. As you could see in the list, this slide it explains everything here. We have the fentanyl as opioid. It is the most effective analgesic medication, but it is the most harmful medication. So when we combined our all multimodal analgesic, as you could see here in the slide, we will have more effective, and we are in the safe area, in the safe side. Here is how we could approach our comprehensive analgesic plan for our cardiac surgery. Here is the conclusion from the stewardship. This is our practice in Saud Al-Babtain Cardiac Surgery Center when we implemented our ERACs. This is our guidelines, and you could see there is a perioperative multimodal opioid sparing pain management plan. We reached over the last three years, we reached to opioid-free cardiac anesthesia. We started to reduce our opioid gradually till we reached to totally opioid-free cardiac anesthesia in September 2023. And here are our OFCA on September. This is our protocol for our cardiac surgery when we implement our opioid-free cardiac anesthesia. Total number of cases we're reaching to 200 cases. I cannot share with you our data at this time since we were planning to publish it. So we have very positive outcomes, results, and we are continuing our multimodal opioid-free cardiac anesthesia and center. But we observe very short ventilation time, shorter length of stay in cardiac surgery, and length of hospital stay. The take-home message here, pain management in cardiac surgery setting is a growing area and appears to be under-investigated compared to non-cardiac procedure. The multimodal opioid sparing cardiac anesthesia is safe and visible, as I presented to you in the previous evidence. Available evidence support the adoption of an opioid sparing with multimodal pain management in cardiac anesthesia. Yes, we need to have more RCT, and then everybody will change their practice from high opioid to opioid-free cardiac anesthesia. Thank you very much.
Thank you, Professor Zaki. We are already 30 minutes late, so we'll start discussion with the last speaker because he's online. We'll get benefit of his presence now. So if anybody have question to Professor Zaki, please. If no, we'll move to the, okay.
Dr. Zaki, thank you very much. I'm a cardiologist, actually. My question regarding your procedure, it is nerve block for this patient. You do it intraoperative or post? Because I'm doubt regarding the advantage of this maneuver?
Okay, I totally understand. It needs more explanation because I need to review with you the pain pathway. But I would make it very simple. The brain pathway. Imagine there is a surgical trauma at the chest, sternum. There is surgical trauma. There is neuroendocrine hormonal release at the tissue level, damage. And there are signals going through C fibers to the posterior horn of the spinal cord, then to the intramedullary, then to the brain. So we will feel the pain, okay? What happens when it comes to opioid? Opioid will block the pathway at one receptor, one level, we call it, one chain, one level. When we use multimodal, we use dexamethasone, we use pregabalin, gabapentin, we use dexamethasone, we use lidocaine, we use magnesium sulfate, we use ketamine. All these they block the pain pathway at four different levels. So even that's why we have better hemodynamic stability when the patient wake up. They will not have a fluctuation. One point I did not mention that even the post-operative bleeding, the drains are less with opioid-free cardiac anesthesia because we have a better hemodynamic stability rather than fluctuation. And this hemodynamic stability, because we block the pain with different modalities of medication at different level. But opioid, it blocks the pain at one level only. So as you know that opioid has mu1 and mu2 receptors. The mu1 it blocks the pain. The mu2 has the whole side effect. The itching, the nausea, vomiting, shifting the CO2 curve to the right. So patient will have more of hypercapnia, postoperative respiratory acidosis, and cause the confusion, the constipation, and so on. And so we do not do for sternotomy, we don't do block. We do not do block. We do block only for the minimal invasive. We observe patient postoperative, they require only paracetamol, 1 gram Q6 IV, and sometimes they require some tramal only. They do not require fentanyl infusion or opioid infusion with very good pain score, by the way. And it is in the literature, it's been documented. The postoperative pain control and pain score is better with opioid-free anesthesia. In non-cardiac, it's been for a while the practice of opioid-free anesthesia. In cardiac surgery, there are few centers in the world, by the way. It's a new concept, and it is more challenging, but for post-operative recovery and outcomes, for sure, the opioid-free is much better. For intraoperative, yes, it's a comfort zone for the surgeon, for the anesthesiologist, for the whole team. That we give one medication, we keep the infusion, and everything is fine. But post-operative complication is the major issue. With multimodal, we need to give around 6 to 7 medication in order to achieve the anti-nociception response. The one I talk about it in the first slide, analgesia versus anti-nociception. And I hope this answers your question.
Thank you, Professor Zaki. But due to shortage of time, we will move to the other speaker. If anybody have question to Professor Majid, to Yasser and Majid and Tayyib Fadl, please. We are already late, more than 30 minutes. Any questions? Okay. Dr. Osama? Thank you, Dr. Zaki. If you want to keep with us, okay. Because no more question to you.
Thank you very much. I apologize. I need to leave. Thank you very much.
Thank you, Professor Zaki.
Thank you very much.
I have a simple comment about the lecture of Dr. Tayyib Fadl about the primary PCI. Really, we have problem with the primary PCI regarding, as Dr. Tayyib mentioned, about the financial issue. About the financial issue, yes, this is the big problem. Another problem, I think also the same problem we face in our hospital, not in the, as in the Markaz Nabd al-Haya, also in our hospital outside. The next point about the doctor in emergency. Doctor emergency must be oriented about the acute coronary syndrome and those with present with acute ischemia, because doctor emergency is the corner point in this. He can direct the patient to the either thrombolysis or to the primary PCI when the patient present in the first 3 hours. Some patient has no financial, okay, but don't lose the value of the thrombolysis. Don't miss the value of the benefit of thrombolysis. Don't miss this chance for the patient. Thrombolysis also we have a challenge about this. عندنا only one thrombolysis streptokinase. طبعا في thrombolysis better than this but not present in our country. لكن يعني زي ما يقول المثل يعني كازوزة ولا غدرة. Thrombolysis streptokinase it is really has a serious complication side effect, but it is very benefit because some patient, many patient apply for him thrombolysis streptokinase and advised for I did for this the patient coronary angiography. The same artery sometimes become patent or sometimes total occluded become partially occluded. So the benefit from the thrombolysis is very important. So don't miss the chance for the patient regarding this. The third point regarding the intravenous anticoagulation enoxaparin. This point mentioned in the guidelines in the emergency to give the patient with STEMI intravenous enoxaparin 30 ملغ intravenous. وهذه ما أشوف أنا تعمل في الطوارئ. فدكتور emergency must be oriented about this point because this point mentioned في الجايدلاينز انه المريض اللي يجي لك بستمي اعطيه 30 ملغ انوكسابارين وهذا بيساعد في فتح الشريان في كذا حتى لو كان المريض معمل برايمري بي سي اي. فهذا very important in addition to the aspirin وكلوبيدوغريل loading dose and like this. هذا point. البوينت الثانيه regarding the cardiac biomarkers CKMB وتروبونين. Really troponin, cardiac troponins is highly sensitive and highly specific, especially with high sensitive assay test. But also CKMB has value not has the troponin has. What is this? هو for recurrent diagnosis of recurrent myocardial infarction, because the troponin still last يعني duration حقه 10 days إلى 14 days. While CKMB after 3 days return to normal.
Dr. Osama, please. This is a comment more than a question, as you said.
Okay.
We can discuss it in the break because we have all the time. Sorry.
Last issue, Dr. Ali, regarding the financial support, because you are the head of administrative comment in Al Arab Hospital. Also, we face this problem. I hope to discuss this later on about this.
In the breaks. Okay. Thank you. Any more questions? Or اوكي دكتور طارق.
تكمله نفس الموضوع طبعا بس باختصار. طبعا اطبائنا اللي في العنايه المركزه في مستشفيات ما فيش فيها الفاسيلتيز للبرايمري بي سي اي، هو انه اذا اعطيت الثرومبوليتيك وهو الستريبتوكاينيز المتوفر فعلا في حاجه يعني تنتظر 90 دقيقه. اذا في ريسبونس للثرومبوليتيك في ديكريز بالاستيليفيشن الشيست بين ديزابير اوكي يمكن تخلي المريض عندك مثلا لليوم الثاني بالاي سي يو، لكن في انا لاحظت كثير انه بيبقى المريض بالاي سي يو رغم انه there is no response. اذا ما في ريسبونس للثرومبوليتيك you should send the patient for rescue BCI immediately. ما تخلي المريض عندك في الاي سي يو. شكرا.
I have a suggestion. If any questions, we can keep it for the break. You can ask because we have the 3 speakers available. They are physically attended. We can get benefit of time. We announce the break, and then if you have any question, we have already give you 2 chances. We have to give anyone have questions. We have already give you 2 questions. I think due to shortage of time, better to go for break. Anyone who have question, they can ask the speaker directly. Thank you for everybody participating in this session.
يا شباب السيشن الثانية الآن تبدأ، مش بريك دحين، ما في بريك. تفضلوا ارجعوا. أستاذ الدكتور أحمد بحاج تفضل. الدكتور عمر باسلم تفضل. دكتور عبد الخالق بن نهيد.
الميتنج حق الاونلاين يكون في نقاش ولا طبعا؟
دكتور محمد الفلق. لا ما في. تفضل تفضل. لا ما في بريك. الساعة 12 بريك مش الحين. الساعة 12. الساعة 12. تفضل. دكتور محمد الفلق. دكتور عبد الخالق. ايوه هناك من هناك خلي حق. طيب بسم الله الرحمن الرحيم. شرفني في رئاسة الجلسة يكون معانا أستاذ الدكتور عمر باسلم، أستاذ أمراض القلب والأوعية الدموية بجامعة عدن. وشرفنا كمان الأستاذ الدكتور أحمد بحاج، أستاذ أمراض الباطنة كلية الطب جامعة حضرموت. وشرفنا الأستاذ الدكتور عبد الخالق بن نهيد، أستاذ الأشعة جامعة حضرموت. والدكتور محمد الفلق أخصائي أمراض القلب والأوعية الدموية بسيون. شرفنا في السيشن. عندنا أول محاضرة لايف ترانسميشن فروم صنعاء من الأستاذ الدكتور عبد الناصر المنباري والدكتور أستاذ الدكتور نور الدين الجابر. بروف عبد الناصر you are with us. بروف بروف تسمعوا؟ كان يسمع. الصوت مش واضح.
الآن الصوت واضح؟
أي نعم. ما شاء الله. فكرة جديدة إنه حيتعمل نظام استوديو ولايف ترانسميشن كأنهم موجودين معنا في القاعة. السلام عليكم. الصوت لا. لا الصوت we cannot hear you.
Can you hear me now?
You can hear us.
أيوة إحنا بنسمعكم، أنتوا بتسمعونا كويس؟
أوكي.
الآن واضح؟
تفضل.
بحدثكم اليوم من صنعاء إلى مدينة المكلا، مدينة الجمال والأصالة. ما يبدأ بقبس ينتهي بمشعل، وما يبدأ بفكرة ينتهي بسمو. سمو هو فريق طبي تطوعي تأسس على أكتاف الخبراء والاستشاريين، ويضم مجموعة من الطاقات الشبابية الموجودين اليوم معنا، ويختص أنا أول واحدة منهم. ويختص الفريق بإقامة المؤتمرات والندوات العلمية والنقاشات العلمية. نحدثكم اليوم من سمو ستوديو، المنصة الرائدة في التعليم الطبي المستمر. والتبادل العلمي والمعرفي، حيث نعمل على تنظيم الفعاليات وورش العمل الهادفة إلى تعزيز المعرفة وتطوير المهارات. يسعى سمو دائما لتوفير بيئة ملهمة للمشاركة، مما يسهم في تحقيق أهداف سمو في رفع مستوى الكادر الصحي. أرحب بأساتذتنا الأفاضل البروفيسور عبد الناصر منيباري، former Health and Population Minister, Cardiology Consultant, Adjunct Professor of Medicine at UPM Malaysia, 2004, Professor of Cardiology at the Faculty of Medicine at Sana'a University, and Professor Nuruddin Al-Jabir, Cardiology Consultant, Professor of Cardiology at Sana'a University. هنبدأ الآن مع البروفيسور عبد الناصر with his lecture title, May God Forgive Me, It Is Not a Zebra, It's Really a Dilemma. هنبدأ الآن السكرين شير.
بسم الله الرحمن الرحيم. بداية على نشاطه العملي والعلمي. وفعاليات مؤتمر القلب الثالث هي فعالية دكتور طيب، كيف الصوت؟ تسمعونا؟ الو؟
ايوه بروف، الصوت واضح ومسموع، تفضل.
طبعا اشكر مركز نبض الحياة على الفعاليات العملية والعلمية. والواقع انه يعني انا اعتذر عن انا طبعا وزميلي نور الدين عن الحضور لاسباب شخصية جدا، لكن ان شاء الله نوعدكم في فعاليات قدما ان شاء الله نكون physically attended، وخصوصا في وجود ضيوف كرام من طبعا اصدقاء نبض الحياة باستمرار. احب ان اشكر ايضا فريق سمو وشركة بليم على استضافتنا لهذا الاستديو. والواقع يعني قد يكون عنوان المحاضرة غريب نسبيا. يعني طبعا الإنسان بتمر في حياته حالات قد تغير مسار حياته، أو قد تحس في القلب إنه ما سوى شيء إضافي للحالة. فيمكن حالة اليوم هتكون مثل لمثل هذه الحالات. الواقع إنه المريض هذا حوالي 67 سنة، مزوج ويشتغل خياط، ومن كان يخزن ويدخن، وما فيش معه أي history of diabetes or hypertension. الواقع المريض هذا بيحول أو حول لنا من أحد الزملاء في أحد المراكز لعمل إيكو، لأنه كان معه إيكو من أول على أساس أنه hypertensive heart disease. ولما سألنا المريض أنه بيتضح أنه المريض عنده severe shortness of breathing NIHA class 4 مع paroxysmal nocturnal dyspnea، وكان في easily fatigability وباراتيزيا، ومعه شيء يشبه الكاربال تانل syndrome. وthrough urination, when we ask about his urinary component, and there was mild lower limb swelling, and most of the other symptoms were irrelevant. طبعا we review his laboratory workup, and we ask also for other investigation. Apart from slight anemia, examination including liver function, kidney function test, thyroid function test, autoimmune screening was all negative. Even troponin and the 24-hour urine collection was negative for this patient. And if we see his ECG, it looks like severe left anterior hemiblock or severe left axis deviation and left atrial dilatation or enlargement was there. So in this ECG, it looks like incomplete left bundle branch block. His X-ray show cardiomegaly with left ventricular configuration, unfolding of the aorta, and severe lung congestion. So up to this extent, we make an abdominal ultrasound and the skull X-ray, BA and lateral. The abdominal ultrasound show only congestive liver and minimal right-sided pleural effusion. Otherwise, all the investigation was normal. So till this extent, we was in dilemma. And here I will put here in take-home message before going to the next slide. So when patients refer to us for doing echocardiography, as usual, our colleague in the other centers, they refer the patient directly for echo or sometimes for coronary angiography without ECG and X-ray, or sometimes even just to reach the final step of this patient. But when I auscultate this patient, there was no accentuated second heart sound. And this is pay my attention to a different diagnosis rather than hypertensive heart disease. So when I did echo, so when I did echo for this patient, actually it was astonishing for me to do echo. Usually when I do echo, I do just a quick look to see. It seems from the echo it's severely hypertrophied left ventricle with a spotting signs in the left ventricle. So it's not a regular case of hypertension. It's I think it's something else rather than hypertensive heart disease. The patient was having mitral regurg and tricuspid regurg with this severe hypertrophy of the left ventricle. So what do you think? What could be the diagnosis? Could I ask my colleague, for instance, I will forward the microphone for Dr. Nuruddin to give some input in this area. What do you think? What's the diagnosis could be?
Assalamu alaikum wa rahmatullah. When I say in this clinical scenario, this ECG change and echocardiography, we can expect this patient one of the infiltrative disease and we indicate for differential diagnosis. One of the most important hints you see in echocardiography, present of mottling-like appearance in the cardiac muscles. وبقية التعليق للبروف نانسي.
بسم الله الرحمن الرحيم. شكرا جزيلا واهنيكم على هذا الايفنت الرائع وأبارك للأستاذ الجميل الدكتور عبد الناصر النباري على هذا الإنجاز سواء عندكم أو عندنا مع إنجازاتنا وإلى أنا بالنسبة لطريقة الدكتور عندك disease we have a lot of processes but in this case the hypertrophy is marked and then expected واضحة. We need to see if there is a mechanical fusion and that can thickening of the lateral septum and the apex sort of you know
I agree totally with my colleagues that this case is unusual. It's not hypertensive as far as the septum and the posterior wall is more than 15 millimeter. And this slide here shows us the hints if the thickness of the wall is more than 15 millimeter, we have to think about some diagnosis. If it is less than 15 millimeter, we have to consider restrictive cardiomyopathy. Actually, when we go with this patient, we found that this patient is going for more giving ends to amyloid or amyloidosis for the heart. So actually, amyloidosis is a big dilemma for us. What's the dilemma for amyloidosis? Amyloidosis, I think we have to depend on cardiac MRI to diagnose it. And usually cardiac thickening and atrial dilatation, but diffuse late gadolinium enhancement is characteristic in the left ventricle. And also the thickness of the right ventricle should be there, and late gadolinium effect should be there. Dark blood pooling is there, and pericardial effusion and pleural effusion is there. Is cardiac MR is diagnostic? Of course, biopsy is very important in such a case and considered a guideline or a marker for putting the actual or the flagship diagnosis in this case. So if we don't have cardiac MRI, I think I will miss this case. I will not put a full diagnosis. I will put maybe or could be or high possible, high probable, but definite diagnosis or nearly definite diagnosis with cardiac MRI. And I will forward the microphone for my colleague, Dr. Noor, to give us hint about constriction versus restriction in the heart.
So by this time, I guess I'll go through the echocardiography and my talk about either constrictive or restrictive and the dilemma of these things. Thanks, Prof. Nasser. Innovational language. So I'll just go through the small introductions. So at the beginning of my talk, I have nothing to disclose, a matter just of continuous medical educations and to share you in your nice conference, also to share Sumo team in their studio. One of the most important disclosures to me, I was sharing these lectures with Professor Alessandros Salceretti, one of the Cleveland Clinic professors. So I promised him that when I'm going to talk about these lectures, I will just quote his name that he's sharing me. So I'm going to talk, the agenda is like that. Introductions, I give you some brief cases, the facts of hemodynamics, what's the echo findings, and then I will give you the final or conclusions in this message. Albert Einstein, he said that theory and practice are the same, like in theory, like in practice, they are not the same. So just, all of you know this anatomy, how the heart is composed and the layers of the heart, starting from the endocardium to the fibrous part of the pericardium. So if you just give some definitions between restrictions and constrictions, I think all of them, they will share this information and it will be like that. So usually the heart disease, both of them, they are heart disease resulting.
Please, Dr. Noor, the sliding is not moving.
Now it's moving?
No. Can you check?
Okay.
Okay.
You see the slides now, okay?
Yeah.
So if you give the definition, it's okay. Voice is clear. Dr. Tayyib, I saw that the slide is in front of you. You hear me?
Yeah, we hear you, and the slide is moving. Is everything is okay?
So the heart disease is resulting in impaired ventricular filling, both restrictions and constrictions. They are highly diastolic pressure required to maintain the cardiac output, and systolic function usually in both type of disease it is normal. So again, the left ventricle or right ventricle biventricular failure, it will be present. There are a lot of cases, as Prof. Nasser mentions. So this is a broad categories of disease can affect the myocardium, leading to restrictive cardiomyopathies. And again, if we see constrictions of the heart, it will be either tamponade or constrictive pericarditis, or effusions with constrictions. And also, again, many diseases can cause these things. Either it is infectious, traumatic, or post-radiations, or chronic inflammations, sometimes uremia and neoplasm. If we just do comparison between two types of disease, constrictions versus restrictions, both of them, they are in heart failures and share GVB is elevated in both of them. They are in gallop or knocking in both of them. The left ventricle ejection fraction will be normal, and the ECG is not specific for both of disease. So mostly they are sharing many things in the same view, and there are a lot of differentiation between the two diseases, and it is very long dilemma. It's giving the person headache. So how we can differentiate? So what's the tools to differentiate between these constrictions and restrictions, leading to paradoxical diastolic failures or have BEV signs? So the diagnosis should be given in hemodynamic change between the two different types of disease. So it will depend on the pulse, diastolic failings, the relaxations, E prime type, and the hepatic vein reversal, left ventricle or right ventricle pressures dependence. So if we give you guys very rapid this scenario, patients 45 years old present with typical symptoms and signs of heart failures. I'll go rapidly because of time. If you guys see, this is mostly it is the same case which is presented by Prof. Nasser. Same mottling-like appearance, which present like heart failures, and you see the echo characters in this biatrial enlargement with mitral and tricuspid regurg, and both ventricles are normal with hypertrophy. So simply you can set this case, it is a restrictive cardiomyopathy. If we see another case, same dilemma, the same symptoms, but with different patients, we'll see again both atrial is enlarged, and we can see also, if we see the pericardium of this patient, if you see it in your image, you will find that the pericardium is a little bit thick, and this case is, we consider it by echocardiography with other manifestations like constrictive pericarditis. The third scenario, just to see one patient is like that, the same things, present with signs and symptoms of heart failures, but what's the difference between this case and the other cases you said before? If you see this patient taking pericardium with some fluid beside the pericardium, so we can set this case, it is a case of constrictive erosive. Again, you will see hypertrophied heart, so this is one of the mixed disease you can see in one patient. You can see restrictions, constrictions, or effusive constrictive disease. So the different scenarios give the same clinical data and the same clinical pictures. This raised to our brain the cases, restrictions or constrictions. So this is the questions that should be kept in your mind, and we'll try through this couple of minutes to solve these questions by echocardiography. So restrictions versus constrictions, both disease, it will be clinically the same. Restrictions, it is not treatable, but just only by medications, but constrictions could be improved by surgery and to solve the problem. So they are sharing same disease, same pathology, and the restrictions affect mainly the myocardium, and the constrictions affect mainly the pericardium because of different etiology. So you can overlap between both hemodynamics. So what's the fact of hemodynamics? The constriction, the pericardium is not cover all the heart. They spare the left atrium from covering. So they meet what we call is interventricular interdependency. You can study it L by cath, well by cath, or by echocardiography. It depends
because the pressure inside the heart, it will be depends on itself if there is constriction. So it is spare the thoracic pressures. But the restrictions, it will not affect the heart, so the flow it will be the same in a cardiac chambers. So again, simple differentiation in hemodynamic, the precardial compliance in constrictions it will be decreased, myocardial compliance in restrictions it will be decreased, the pressures transmissions in constriction it will not be the heart pressure different from the chest pressures, and the ventricular interactions it will be more in constrictions because it depends on the flow inside the heart. That's what we call it is ventricular interdependency. So through these introductions in different type of cases, I will go rapidly through the echocardiography, what you will see and how you can differentiate. Actually, in some references, they said the differentiations in echocardiography, it will reach the sensitivity up to 87% and the specificity reach 91%. So if we just see, is it recommended to use an echocardiography in such dilemma and to differentiate between different type of cardiomyopathies? The answer is yes, and considered to be class 1 B level of recommendations in last European Society guidelines. So what we are going to see there, we'll see different layers of the heart, starting from the outer layers to the inner layers. So if you see that precardium, if we find that the precardium is thickening, reach more than 5 millimeters, highly suggestive of constrictions, the TEE is more sensitive rather than transthoracic, even it is correlated with CT scan and the other the next speakers. I think you will have another ideas about these things. Again, we can see in the precardium in echo the precardial thickening or effusions. You can see it in different cases. It gives you a hint this is constrictions. If we just note the cardiac muscles in echocardiography M mode, you will see notching of the muscle in the node that the pointer is up. It is here, and you can see the notching of the muscles. And what we call it is the rapid uptake of myocardium in the diastolic to systolic area. So like these things, and this is also give you a hint. This patient is a case of constrictions of the heart. So again, if we see the myocardium having what we call is moving inside the interatrial septum and dependence in the flow between the two ventricles, when the flow is high in the left ventricle, so it's pushing the septum to the right. When the flow is high in the right side of the heart, it will push the septum to the left. What we call it is the septal bouncing. It will be clear to see it in echo. If you just observe this case, you will see here the septal bouncing. In this case, it's just shifting when the flow is going to the right or left. And this is in short axis. You will see the septal bouncing. It is clear. Again, we could concentrate in the myocardium of patients. You will see some mottling-like appearance in hypertrophied heart. This is also give you a hint in infiltrations, and again more cases to see like pictures in amyloidosis. Then the Doppler flow, it will be affected in such type of diseases. We take three important Doppler: the mitral flow, pulmonary flow, hepatic vein flow. It just represent extreme form of diastolic dysfunctions. So the last four. This is just the diastolic or A ratio is going functionally in age. So start from young up to the severe form of diastole. In constrictions or restrictions, you will find the last form. So it's a highly peaked E and the short A, and this is just sign of constrictions. This is when you are going to do a Doppler in a mitral flow, the A ratio will exceed 1.5 and decelerations time less than 160 milliseconds. So even we can use it to see the variations between A and A during respirations, and they made some equilibrium to see how the differentials. If there is decrease in 25% in mitral A velocity in respirations, so this is mostly goes with constrictions like this picture. It is one of the hallmarks you can differentiate between constrictions or restrictions. So in restrictions, again, just to remember, there is no respiratory variations in mitral, just only in constrictions. In pulmonary venous, you will see gas refers in systolic and diastolic velocities with expirations. Again, you can expect constrictions and different form of constrictions or constrictive erosive disease. This is just how you see the different things in left ventricular pressures and mitral flow and pulmonary flow. So just if you see the last one on in your I don't know, left side, so you can see this is a constrictive form in mitral or pulmonary veins, and you can differentiate between both diseases. Actually, the T is more clear things. You can see it in echocardiogram. One of the most important items, because you will see the inferior vena cava. It is dilated or fixed. More it will be in constrictions rather than restrictions. One of them it will be fixed or dilated vena cava, like what you see in the pictures. The other parameters in hemodynamic studies by ECOS is the hepatic vein. You will see decrease the diastolic flow of the first expiratory beat, and there is also reversal of flow. You will see, if you see gas reflections of the flow in these pictures, indicating that these patients had constrictive disease. And this is just to differentiate between different type of Dopplers in different form of disease. One of the most important parameters to be used in constrictive or restrictive to do what we call tissue Dopplers in mitral valve annulus. So just how you will do it, you will analyze the pulse Dopplers in mitral valve annulus, either in both sides, in septal aspect or lateral aspect. This is just, you will see the pictures they are doing in the transducers, keep in pulse Dopplers in septal aspect, or you will keep it on lateral aspect. They simply just how to do it, keep the machines in TDI, then again make it close to zero, and then do good filtering, keep the speed of the machine between 100 to 200 milli per second, and then you'll do it. This is just an example how to do it. You just put the pulse Dopplers here, if it's clear to you, just the septal form, and then you will keep it in the other place if you are going to study the lateral flow. So to give you these pictures, and then how we can differentiate this is constrictions or restrictions in such tissue Doppler study. The result it will be like that. If the septal E prime exceed 7 centimeters per second, some boxes they will write 8 centimeters. So, or the lateral E prime less than the septal E prime, this is a constrictive form. If you see just the septal E prime less than 7 or 8 in other references, or the lateral E prime is more than septal E prime, this is type of restrictive cardiomyopathy. This is just simple things. It is got to differentiate. The new modalities of echocardiography, again, you can see how's the heart moving, and you just going to study the septal tracing of myocardium deformations. Again, will give you a hint how to do it is constrictive or restrictive in different forms because of the times is going and going fastly. Some pitfalls it can happen in such patients who had respiratory disease like COPD, or you cannot help you in respiratory variations, and many studies prove that we can sometimes get mixed between the two cases in respiratory disease. So just keep it in your mind to differentiate between the things. So still the questions towards restrictions or constrictions, it is the questions which will be there. I think the solutions is restrictions or constrictions, no more questions. So we can simply by echo use it to differentiate. I will give it in summary how to do constrictions versus restrictions. The common features in echocardiography: go immediately after you see bilateral enlargement and the ventricles looks to be within normal, go to the mitral inflow. E, it will be very high. A ratio is exceed 1.5. The deceleration time less than 160 milli per second, dilated and fixed inferior vena cava. So this is just the first item, keep them in your mind. Then the septal bouncing, it will be present in constrictions. Restrictions, it will not be. So mitral annulus tissue Doppler imaging, if E prime in septal more than 7 centimeters per second in constrictions, less than that in restrictions. The E septal it will be less. The E lateral, E prime lateral less than E prime septal in constrictions, it will be less. end restrictions, the E prime lateral more than E prime insectal. This is just depends. The myocardium is affected, so the E prime in the septal it will not be affected. The E prime in the lateral it will be affected, which is close to the pericardium or close to the muscle. Just to keep it in mind is like that. And we see the mitral flow, the tissue, the tricuspid flow and the hepatic flow. Just the different things in constrictions, restrictions, it will be clear if you differentiate between both of them. Septal strain in constrictions usually normal, bilateral enlargement more in restriction rather than constrictions, pulmonary hypertension and restriction more than the constrictions. Mitral and tricuspid regurg, it will be more in restrictions because of muscle involvement. It will affect the papillary muscle of both valves. Many scheme and guidelines, they do it how to follow or how to differentiate between both of them. So if you just follow these instructions and then how to follow this scheme and to do the echo in a proper way, you can differentiate both of them. So at the end, what I can tell you that the disease has an important therapeutic implications. If restrictions, so it will be medically treated. If constrictions, usually it is surgical treated, can solve the problem. Clinical presentation, both of them is the same, is diastolic failures. Historical etiology helpful, but it will not be diagnostic. Take pericardium, sometimes it is not necessarily causing constrictions. Just to keep it in mind, a restrictive process may be also constrict. So just keep in these things, echo and hemodynamic features may be overlap. So if the dilemma still things there, so we can use other modalities, other facilities to study the cases well. So by the end of this talk, I think all of you, so we just keep the phone for Prof. Nasser.
Thank you, Dr. Nuruddin. I think if we have one question, and this question is very valuable because it gives a prize from شركة بليل تذكرة سفر إلى مؤتمر كارديو إيجيبت. فأحب أوجه الميكروفون للدكتور نور الدين ليعطي السؤال، والإجابة تقدم للدكتور طيب ويعمل القرعة مع الفريق الإعلامي.
طيب تسمعنا؟
Okay. Thank you very much دكتور نور بروف ناصر على this illustrative وعلى focus of one of most common disease we see it and misdiagnosed as a constrictive pericarditis or restrictive cardiomyopathy والamyloidosis. الآن في سؤال حيتوجه من السيشن. الجماعة كل واحد مع مذكرة في الشنطة حقه، نبغى يطلع ورقة ويكتب اسمه والجواب حق السؤال. تمام؟ وآخر السيشن حتتجمع الورق من الشباب منتدى موجودين على المداخل وانتم خارجين على البريك، وحيكون بإذن الله السحب بكرة على الإجابات الصحيحة مبلغ ودعم من شركة بلم لحضور مؤتمر كارديو ايجيبت. فالسؤال الكويستشن بروف
تسمعونا جميعا؟
ايوه بس خليك على لايف يا شباب.
الأوراق جاهزة؟
ويت. السؤال
موجود الآن عندك على الشاشة، أنا شايفه. أقرأ. تسمعونا أنتوا طيب؟
أسمعك بي.
طيب احنا دائما في اليمن عندنا يمكن rheumatic heart disease is very common disease, we see it frequently in our daily practice, and we see what we call is rheumatic activities. It affects many patients. These rheumatic activities, as you know, it affects from the endocardium till the pericardium. All the layers of the heart could be affected by rheumatic activities. Precardial affections in form of pericarditis is common in rheumatic heart disease. ولحد الآن يمكن ما شفنا مريض عنده بريكارديال وول ديسيز روماتيك اكتيفيتيز عنده constrictive pericarditis. السؤال why rheumatic pericarditis is not prone for constrictions. أنا عملت السؤال challenging لأن الجائزة كبيرة والسؤال له فائدة علمية وباع علمي كبير عشان بس نعرف كيف نتعامل مع مرضانا بشكل عام. شكرا جزيلا لكم.
طيب we keep the slide please. Why rheumatic pericarditis is not prone for constriction. تمام نبغى الإجابة تحط في ورقة واحتفظ بها لو سمحتوا إلى ما تخلص السيشن وبعد كده تسلم. حنصحح الورق وحنرفع النتيجة غدا إن شاء الله. لا الجائزة قيمة، الجائزة قيمة تستاهل. Okay, thank you very much, Dr. Abdel Nasser, Prof, Dr. Nouruddin. Thank you very much for سمو على الفكرة الرائعة حكاية الاستوديو، وصراحة هذه أول مرة تعمل وفكرة جميلة جدا. Thank you very much. في أي أسئلة أو سؤال موجه لطاقم البروف أو شيء قبل ما ننتقل للنكست سبيكر؟ Thank you very much. في سؤال بروف عبد الناصر you are with me؟
ايه طبعا.
معنا دكتور سؤال من الدكتورة إيمان بصديق، تفضل.
السلام عليكم ورحمة الله وبركاته. Prof. Abdul Nasser Monibari and Prof. Nouruddin Gaber. Our expectations were to see you live in this scientific annual meeting, but unfortunately, due to your personal affairs, we are so happy at least to see you on a Zoom meeting. Concerning amyloidosis, I think thinking of a primary or a localized is very rare, but we have to think here it could be a secondary amyloidosis. And in our setup, in our community, the first differential diagnosis we should think of is it may be related with some chronic inflammatory diseases. One of the most common is tuberculosis, and the other is rheumatic heart disease. So I wonder if this patient should be screened for tuberculosis, even though your echo findings did not suggest any rheumatic possibilities on this patient. The other point about restrictive cardiomyopathy or constrictive myocarditis, cardiomyopathy, also I think in our setup, tuberculosis should also be considered as one of the underlying causes for it. And thank you very much.
شكرا جزيلا بروفيسور إيمان. الواقع احنا فعلا نتمنى ولغاية آخر لحظة كنا بنحاول، لكن الظروف فعلا صعبة بالنسبة لنا. very special personal issues، وإن شاء الله نلتقي في لقاء قادم وفي كارديو عدن أيضا ممكن نلتقي. بالنسبة للسؤال الأول أميلودوزس، فعلا المريض هذا احنا فكرنا في secondary issues وعملنا له screening لتوبركلوزس، لأنه فعلا التي بي is very common in our community. لكن الدايلما هنا مش في التشخيص فقط، لكن how to treat أيضا. هذه very complex issue, especially in a patient with amyloidosis. The vasodilator مثلا nitrates or even ACE inhibitor, calcium channel blocker, may deteriorate the case more. And these patients are liable for digitalis toxicity more than other people. So we have to be very careful for this patient. ممكن diuresis, ممكن anti-arrhythmic class 3, ممكن anticoagulation, and sometimes we could use. Otherwise, the regular heart failure medication may deteriorate the case more. For restriction and constriction, I will forward the microphone to Professor Nuruddin to respond to your question.
بروف إيمان، أنا دائما أسعد بأسئلتك وأسعد بوجودك أنت والدكتور الكريم، وأسعد بلقائكما دائما، لكن الظروف وإن شاء الله نلتقي دائما. دائما نحن لما نحصل constrictive pericarditis السؤال اللي يطلع في بالنا TB or not TB، فدائما نحطه كده، وعشان كده يمكن حطينا السؤال هذا why rheumatic pericarditis is not prone for constrictions like tuberculosis. فدائما احنا بنعمل screening for our patients، لو حصلنا بس حتى minimal pericardial effusions وبداية thickening of pericardium، again we send the patients for tuberculosis screening and investigations. وشكرا لسؤالك.
شكرا لكم على استضافتكم، ونتمنى أنه كانت المحاضرات insightful وكان البث smooth، ونتمنى لقائكم إن شاء الله في مؤتمرات قادمة، وإن شاء الله نكون in person. شكرا لكم.
شكرا. Our next speaker, I will introduce Professor Muhammad Ali Salim from Egypt in live transmission. Dr. Muhammad. Dr. Muhammad.
Assalamu alaikum.
You're hearing me?
Assalamu alaikum, Dr. Omar. Ahlan wa sahlan.
Salam wa rahmatullahi wa barakatuh. Ahlan wa sahlan, Dr. Muhammad. Muhammad, who is Professor of Radiology at the Cairo University, he will present the constrictive pericarditis versus restrictive cardiomyopathy, role of imaging. تفضل دكتور محمد. قطع الاتصال. Yes, دكتور محمد.
السلام عليكم دكتور عمر، اهلا وسهلا. حضرتك السلايد واضح؟
اوكي. تمام.
بسم الله الرحمن الرحيم. انا بتوجه بالشكر للساده منظمين المؤتمر على الدعوه الكريمه، وللساده الشير بيرسونز اللي معانا في الجلسه. وان شاء الله نبتدي على طول. احنا ان شاء الله النهارده هنتكلم عن السي تي اند ام ار imaging of in diagnosis of constrictive pericarditis versus restrictive cardiomyopathy. في انترودكشن الاول كده، مقدمه اناتومي. احنا عندنا البريكارديوم بيتكون من تو لايرز، البرايتال layer and the visceral layer. The visceral layer is directly related to the myocardium, separated by from the myocardium by the epicardial fat that contains the coronary arteries, while the parietal pericardium is related to the pericardial fat outside, and the space between the parietal and visceral pericardium contains a small amount of fluid. The pericardial appearance MRI as a low intensity curvilinear structure like this. The pericardium is a fibrous structure, and the fibrous structures appear in MRI low intensity in T1 and T2 weighted images, while the fat appears as a bright structure in the T1 weighted image and less bright in the T2 weighted images. In the CT, the pericardium appears like a thin curvilinear structure around the heart, being surrounded from outside by the pericardial fat and from inside by the epicardial fat containing the coronary arteries, and this helps delineate the pericardium. The pericardium is better appreciated at the anterior wall of the heart, related to the right ventricle, and at the apex, while at the lateral and posterior walls it is difficult or hard to identify the pericardium, being insinuated between the intermediate signal of the myocardium and the low signal of the lung. The pericardium also appears well in the SSP FV steady state pre-precession sequence, used for assessment of the cardiac function as a low intensity line around the heart. The normal pericardial thickness is about 2 millimeter and is considered second if it increased above 3 millimeter. These are two T2 weighted images. Septal bounce is an important sign for constructive pericarditis. The septal bounce, normally the right ventricle begins to fill prior to the left ventricle. And so usually there is transient pressure increase in the right ventricle before the left ventricle. In cases of constructive pericarditis, the pericardium becomes rigid, leading to restriction of the right ventricular movement. And so in early diastole, there is restriction of the right ventricular filling by the abnormal rigid pericardium, leading to movement of the interventricular septum toward the left ventricle at the beginning. Then in the mid and late diastole, the left ventricle starts to fill with gradual increase of pressure in the left ventricle, leading to paradoxical movement or movement of the interventricular septum toward the right side. Then in systole, the interventricular septum moves as a part of the left ventricle toward the center of the left ventricle in a third direction. The normal filling pattern, the right ventricle fills before the left ventricle, and the right ventricle on the lateral wall here is there is a compliance to allow acceptance of the large amount of blood without moving the interventricular septum. While in cases of constructive pericarditis, due to presence of rigid pericardium around the heart, when the right ventricle starts to fill, there is increase in pressure in the right ventricle, leading to a movement of the interventricular septum toward the left side. Then the left side starts to fill, increasing the pressure in the left ventricle with movement of the interventricular septum to the right side. Then finally, in the systole, the interventricular septum return again at the toward the center of the left ventricle. This movement is considered as the bounce movement of the interventricular septum and is considered a sign of constructive pericarditis. The detection of septal bounce occur in either the SSFB sequence, a steady state free precession, and this sequence is an ECG gated with breath holding and has a high resolution quality, help to assessment of the myocardial motion, while the better sequence for assessment of the septal bounce is the real-time SENI image. The real-time SENI image is not an ECG gated images, occurs during free breathing, help to detect the cardiac motion during respiration. During inspiration, there is increase in the negative intrathoracic pressure, and so increase on the venous return, and so the exaggeration of the septal bounce allowed to diagnose the constrictive pericarditis. Restrictive pattern of filling occurs either to secondary to constrictive pericarditis or restrictive cardiomyopathy. Constrictive pericarditis could be of acute or chronic types. Acute pericarditis is a relatively rare entry or uncommon entity. It could be idiopathic, which is the most of cases are idiopathic, and could be infectious like TB, autoimmune, neoplastic, traumatic, iatrogenic, metabolic, or drug-induced. The diagnosis of acute pericarditis depends on the clinical picture, including the symptoms and signs, the ECG findings, blood tests, including the inflammatory markers, and finally the imaging findings. Echocardiography is the first line of imaging in cases of acute pericarditis. In the echocardiography, you can detect pericardial effusion and restrictive pattern of filling of the left ventricle. For patients with chest pain with suspected acute pericarditis, if they have intermediate to high risk of coronary artery disease, so functional anatomic should be first performed, while those with low risk cardiac MRI can be useful to delineate the potential pericardial abnormality when the diagnosis remains equivocal following echocardiography. Acute pericarditis picture in MRI. In T1 weighted image, there is thickening of the pericardial layers with or without pericardial effusion. In the T2 weighted image, there is edema in the inflamed pericardium. Edema means there is a high signal intensity in the T2 weighted images. And in the late gadolinium, the pericardium shows enhancement that indicate inflammation. This case showing a thickened the above images are T1 weighted images. This is a T2 weighted image, and this is a late gadolinium enhancement. In the T1 weighted image, we can appreciate that there is a circumferential thickening of the pericardium around the heart, and in the T2 weighted images, there is high signal in the T2, denoting edema, which is a sign of inflammation, and in the late gadolinium, there is pericardial enhancement, also indicating inflammation. There is another case of acute pericarditis with delayed gadolinium enhancement, showing the hypointense layer in the middle of the pericardium. This represents the pleural effusion, and this is the enhancing visceral pericardium and the enhancing parietal pericardium around the effusion. The pericardium is thickened and enhancing in the late gadolinium images, denoting inflammation. This is another case of acute pericarditis showing thickened pericardium. This is a T1 weighted image, T2 and late gadolinium enhancement. The late gadolinium enhancement shows visceral and parietal enhancement with a central pericardial effusion. In the T2 weighted image, the effusion is high signal, and in the T1 weighted image, the effusion is low signal. This is the epicardial fat, and this is the pericardial effusion. Constrictive pericarditis is usually a chronic disease, but recurrent attacks of inflammation usually occurs. It characterized by pericardial thickening, calcification, and scarring, preserved left systolic function, but with impaired diastolic filling. Pericardial constriction may be present even with normal pericardial thickness or patchy thickening. The typical findings in constrictive pericarditis is dilated atria, tubular-shaped ventricles, and septal bounce, which is the shift of the interventricular septum toward the left ventricle in the early diastole during inspiration. Here is a case of constrictive pericarditis in cardiac MRI showing thickened pericardium with calcification. The calcifications does not appear in MRI, better delineated in the CT images, showing a thick pericardium with low signal intensity in T1, T2, and SENI images. And this case showed lack of enhancement, denoting chronicity. Here is another case of focal constrictive pericarditis. The rest of this area of the pericardium is thickened, exceeding 3 millimeter in thickness, while the rest of the pericardium appears curvilinear with thickness below 2 millimeter, denoting absence of constriction, thickening, or scarring. Here is another case of constrictive pericarditis with calcification. We can delineate the calcification like in this case in the CT images. This is a non-contrast CT image showing dense calcification of the pericardium. And this case shows the tubular-shaped ventricles in cases of constrictive pericarditis due to rigid pericardium or inability to relax of the left ventricle. Here is another case showing an indentation at the base of the lateral wall of the left ventricle. Showing an indentation at the base of the left lateral ventricle by the effect of the calcified thickened pericardium. Here is on the anterior wall, the pericardium appears thickened with spotty calcifications, while in the posterior wall there is dense calcification indenting the base of the lateral wall of the left ventricle. Constrictive pericarditis shows restrictive pattern, which include non-dilated ventricles, preserved systolic function, restrictive filling pattern, and enlarged pose atrium. Pericardial thickening and calcification can appear in MRI and CT sequentially. Pericardial constriction may be present even with normal pericardial thickness or patchy thickening. The MR protocol used for assessing pericarditis includes the anatomy module, the axial T1 and T2 images at the start, the functional module including the steady state free precession cine images to evaluate the cardiac function, and including the right ventricular function, not only the left ventricular, and the real-time dynamic respiratory cine images to evaluate the movement of the interventricular septum during inspiration. And finally, the lead gadolinium enhancement module to evaluate if there is enhancement in the pericardium or not. The report should include the dimensions, mass corrected for PSA, and the function of the left ventricle and right ventricle, and the septal motion during normal and dynamic respiration, and the pericardial thickness and effusion if present, and the pattern of enhancement if present. Restrictive cardiomyopathy. Cardiomyopathy is a myocardial disorder which the heart muscle is structurally and functionally abnormal in absence of coronary artery disease, hypertension, valvular or congenital heart disease sufficient to cause the observed myocardial abnormality. Types of cardiomyopathy are hypertrophic, dilated, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and unclassified cardiomyopathy. Restrictive cardiomyopathy is the least common type of cardiomyopathy, characterized by rigid myocardium, that restrict the stretching and filling of the myocardium, and this presents as a diastolic dysfunction. The most common cause for restrictive cardiomyopathy outside the tropic area is amyloidosis. Other causes include idiopathic, familial, sarcoidosis, hemochromatosis, eosinophilia, and endomyocardial fibrosis. The typical findings in restrictive cardiomyopathy is normal systolic function, but with impaired diastolic function. Dilated atria and dilated atria but normal size ventricles and biventricular myocardial thickening. This is an important issue to evaluate to differentiate the restrictive cardiomyopathy from constrictive pericarditis. Here is a case of restrictive cardiomyopathy showing thickened, diffusely thickened myocardium with dilated both atria and normal pericardium. Here is a case of restrictive cardiomyopathy. There is a case of restrictive cardiomyopathy with amyloidosis. The typical appearance of amyloidosis in restrictive cardiomyopathy is diffuse subendocardial enhancement. As you see here, the myocardium is diffusely enhanced mainly in the subendocardial. At this line, the enhancement is more than other areas of the myocardium. The myocardium is diffusely thickened, enhancing, with maximum enhancement seen diffuse subendocardial. The key point of diagnosis of restrictive cardiomyopathy is restrictive pattern of filling. There is no dilated ventricles, preserved systolic function, restrictive filling pattern with enlarged both atria. The ventricular myocardium is hypertrophied, and in cases of amyloidosis, in addition to the key points for diagnosis of restrictive cardiomyopathy, there is failed or difficult nulling of the myocardium, and this means inability to have an MRI image free of signals from the myocardium. These images are required before injection of the contrast, and we use the inversion recovery technique to create these images. When there is failure or difficulty in nulling the myocardium signal, this indicates amyloidosis. The pattern of enhancement also indicates the amyloidosis when it is a diffuse subendocardial enhancement. Atrial septal hypertrophy occurs in about 20% of cases of amyloidosis, reaching more than 6 millimeters in thickness, and association of pericardial or pleural effusion. البروتوكول المستخدم في حالات الريستريكتيف كارديوميوباثي وبالذات حالات الاميلودوزس، اول حاجه الاناتومي موديول بنعمل axial T1 weighted image. الفانكشن موديول بنعمل steady state free precision cine images to evaluate the right and left ventricular function, and we do the edema module. Edema module, we use the stair or heavy T2 weighted images to evaluate presence of edema in the wall of the myocardium. And finally, the lead gadolinium enhancement to evaluate the pattern of enhancement, if any. The report for restrictive cardiomyopathy should include the dimensions, mass corrected for PSA, and the function of the left ventricle, right ventricle, the regional motion abnormalities, and the thickness of the interventricular septum, interatrial septum, as it increases in cases of amyloidosis. There is also, we should comment on the valve regurgitation and lead gadolinium enhancement, and if presents any pericardial or pleural effusion. Finally, we have some points to differentiate the restrictive cardiomyopathy from constrictive pericarditis by MRI. Number one, constrictive pericarditis show indentation of the ventricular cavities or and tubular appearance of the ventricles due to compression from outside or rigid by the rigid pericardium, and this is not the case for restrictive cardiomyopathy. There is the pericardial thickening in cases of constrictive pericarditis and sometimes calcification appreciated in the CT. There is less prominent atrial enlargement. In the two cases, there is atrial enlargement, but being less prominent in constrictive pericarditis when compared to restrictive cardiomyopathy. The myocardial thickening is seen here in restrictive cardiomyopathy, while in the myocardium shows normal thickness in constrictive pericarditis, and the septal bounce is much more apparent in constrictive pericarditis. And finally, thank you for your attention.
Thank you, Prof. Muhammad Ali Salim, for your nice talk. If any question from the auditorium to Dr. Muhammad, please.
Doctor, thank you very much. I'm a cardiologist. My question regards the advantage of MRI versus CT scan in constrictive pericarditis. Which of which? Just for the patient both, or just to restrict to the CT scan? Thank you very much for you.
The CT scan is important for detection of calcification and sometimes thickening. While all other criteria, including the septal bounce and the cardiac function and volumes, are better evaluated by MRI. The myocardial thickening is better evaluated by myocardial thickening and enhancements. If any infiltrative lesion, as you know, restrictive cardiomyopathy in some cases بيبقى associated with myocardial infiltration زي حالة الساركويدوزس أو الأميلويدوزس. كل الحاجات دي بتبقى أفضل evaluated by MRI. CT بس البوينت في الCT بيبقى أفضل في حالات الكالسيفيكيشن، لأن الفايبرس تيشو والدنس كالسيوم الاثنين في الMRI بيبانوا له سيجنال انتنسي، بيبانوا لهم اسود. بينما في السي تي بنقدر نفرق اذا كان ده مجرد ثيكنينج في الفايبرس بيريكارديوم او كمان في كالسيفيكيشن.
اوكي. ننتقل الان الى النكست سبيكر.
Okay,
Dr. Hani.
Okay, thank you very much, and congratulations for this elegant conference. I have a question from a real case yesterday from our 24 duty patient, adult female, who a known case of end-stage renal disease on regular dialysis. وكلنا نعرف انه واحدة من الكومبليكيشن حق الريجولار dialysis او end-stage renal disease هو اليوريميك pericarditis. Unfortunately, fortunately, البيشنت ايضا هو ischemic heart disease, but not doing any intervention لا BCI ولا حاجة. الكلينيكال اللي جاي فيها هو chest pain، وعلى مستوى الكلينيكال هو كان retrosternal compression وفي radiation، لكن ايضا there is decrease when he's lying on the bed and decrease when he's lying forward. الآن الquestion طبعا انا السؤال هو عشان الاستاذ بيتكلم عن راديولوجي وكده، لكن unfortunately نحن we have a lot of obstacles، من ضمنها عدم توفر البيد سايد ايكوكارديوغرافي او مثلا الكاردياك MRI اللي بيبين لنا والله this is a case of uremic pericarditis rather than this is an unstable angina ischemic heart disease. بيقول لي الواحد طيب الاي سي جي ايش فيه؟ لانه سمبلي الاي سي جي اي واحد جينيور ممكن يقول لي this is ST elevation with upward concavity, this is in all leads، ممكن يكون this is a case of pericarditis، لكن unfortunately البيشنت عنده left bundle branch block مع atrial fibrillation. فالسؤال هذا للاستاذ وللاخوه الكارديولوجي، what I can treat as unstable angina ولا بريكاردايتس؟ وكلنا نعرف مشكله الهيبرين ومشكله الهيموريجيك بريكاردايتس اللي ممكن تحصل لو نحن اعطيناه هيبرين. وشكرا جزيلا وعفوا العطاله.
دكتور احمد علي اسمه محمد علي still available or not؟
ايوه يا فندم، انا موجود مع حضرتك.
ايش السؤال كان؟
الو، ايوه حضرتك سامعني؟
Okay, Dr. Mohammed, you hear the question about one of our
Yes.
colleague. He asked about the patient has chronic renal failure and ECG changes with left bundle branch block or atrial fibrillation and presenting with a chest pain. Is there role of imaging in this diagnosis? هل البيشنت had ischemic heart disease? If the patient has pericarditis, is the role of imaging in this case? What do you think? Especially the patient has a renal problem.
تمام. هو احنا طبعا اولا اللي هو الايكوكارديوجرافي هو رقم واحد. لو هو لو الايكوكارديوجرافي افيلبل ممكن هو هيوجهنا في اتجاه اذا كان فعلا ده كونستركتيف بيريكاردايتس باي الباترن اوف فيلينج، لو هو ريستريكتيف باترن اوف فيلينج ولا ده اسكيميك. لو ستيل القصه ايكويفوكال ممكن بعد كده بننتقل للام ار اي، بس طبعا الموضوع متوقف على الافيلابيلتي اوف ذا ام ار اي. لو الام ار اي موجود وعملنا البروتوكول الخاص بالريستريكتيف كارديوميوباثي، احنا ممكن من خلال نفس البروتوكول ده نفرق اذا كان العيان ده مشكلته اسكيميك ولا كونستركتيف بيريكاردايتس. لان احنا عندنا في حاله الكارديك ام ار اي بنعمل ليد جادولينيوم انهانسمنت. الليد جادولينيوم انهانسمنت ليه كرايتيريا مختلفه تماما في حالات الاسكيميك كارديوميوباثي فروم ريستريكتيف كارديوميوباثي فروم كونستركتيف بيريكاردايتس. لو القصه موجوده ان احنا عندنا delayed enhancement sub endocardial على territorial distribution عند arteries معينه، يبقى احنا كده بنفكر اكتر حاجه في ان هو يكون ischemic cardiomyopathy. لو الانهانسمنت موجود بباترن يا اما باتشي انهانسمنت زي حالات الساركويدوزز او diffuse sub endocardial enhancement زي حالات الاميلويدوز، يبقى احنا كده بنتكلم في ريستريكتيف. بالاضافه طبعا لو كان الميوكارديوم ثيكند. البريكارديال الكونستركتيف بيريكاردايتس ليه كاركترستيك ابييرنس في الام ار اي، بيبقى ديفيوزلي، بيبقى البريكارديوم ديفيوزلي ثيكند وذ ريستريكتيف باترن بالاضافه للسبتال باونس. فهو الام ار اي هيقدر ان هو يفرق، بس هو ما بيبقاش الفيرست لاين اوف ديفرنشيشن في حالات اللي احنا شاكين فيها انها كونستركتيف بيريكاردايتس او اسكيميك كارديوميوباثي. وان كان يعني الايكو دايما هو الاسهل، هو اللي بيبدا الاول، وفي ساينس كتير على الاسكيميا ممكن تظهر من الايكو. لكن لو فضلت الامور ايكويفوكال الام ار اي بيفرق الكونستركتيف بيريكاردايتس فروم اسكيميك اند ريستريكتيف كارديوميوباثي بشكل واضح جدا، سواء النون كونتراست او الليد جادولينيوم انهانس.
Okay, thank you very much, Prof. Mohammed, for your kind presentation, and see you next time soon إن شاء الله. Thank you very much.
إن شاء الله. شكرا.
طيب before going to next speaker رجاء الفيميل side keep silent، أصواتكم طالعة للشارع. Keep silent please. Next speaker it is my pleasure to introduce him. He is my dear colleague and my dear friend, Dr. Hisham Ahmed Al-Faqih. He is a consultant cardiologist, advanced cardiac imaging specialist, academic in Sana'a University, Cardiology Department. He will speak about role of imaging in infective endocarditis.
بسم الله. استعطيني مجال. الصوت واضح؟ chairperson. في أماكن في العالم تحس إنه في شيء بيشدك إليها. صنعاء، القاهرة والمكلا. كل ما أسافر من المكلا أحس إنه في حاجة حترجعني للمكلا من جديد. فإن شاء الله نلتقي أكثر وأكثر بإذن الله. With no further additional ado. The infective endocarditis is a fatal infectious disease that affects the heart, and European Society of Echocardiography and European Society of Cardiology necessitate the importance of having a team to deal with such very fatal disease. And that team is made of cardiologists, cardiac imaging expert, cardiovascular surgeon, and etc. The European Society established a flow chart for approach with a patient who has a suspicion to have infective endocarditis. Once you suspect the disease, you take up a blood sample, search for the persistent bacteremia, and send the patient to do imaging, not only to confirm the diagnosis, but also because you are looking for complications and you're looking for indications that could change your decision, and also to follow the patient during the hospital course and even outside the hospital, I mean after discharge. Let's knock the door for the imaging modalities we expect to find. We have a good list of imaging modalities. We have transesophageal, we have transthoracic echocardiography, cardiac CT, and CMR. We have positron emission tomography. We have WB SPECT with the gamma scan. And if you pay attention for the modalities surrounded by the red line, these are available here in our country. We have the cardiac CT, CMR, transthoracic and transesophageal modalities, and unfortunately we don't have positron emission tomography and wide B SPECT. And let's go to see what the guideline tried to pay attention for. We have three important categories for infective endocarditis. The first one is infective endocarditis with a native valve. We have infective endocarditis on prosthetic heart valve. We have infective endocarditis on top of cardiac electronic implantable devices. And the reason behind such categorization of infective endocarditis is to facilitate using of the imaging modalities that fit each type of the infection, and also use the correct strategy of management. Now, echocardiography, the first and simple, easiest modality available in every hospital, where we can see oscillating mass in the mitral valve and another example of oscillating mass attached to the aortic valve with a severe coexistent aortic valve regurgitation. And this time we have an oscillating mass attached to the tricuspid valve with a concomitant severe tricuspid valve regurgitation. You can see that something playing in the RVOT. With further angulation of the probe, you can see a mass attached to the pulmonary valve. This time we have another scenario. We have a mass oscillating in the prosthetic valve. And I will try to use the pointer here. Okay. And here you can see a pacemaker crossing the tricuspid valve, an oscillating mass here attached to bioprosthetic valve, and a bucket in this area with mostly abscess. Another case of a pacemaker crossing through the tricuspid valve with oscillating mass attached to the lead. So echocardiography in the guideline play important role. And the message behind this slide is to pay attention here for this point, that you need to do a transesophageal echocardiography for all patients with the suspicion of infective endocarditis, even if the transthoracic echocardiography is completely clear and conclusive. And this is the new in this guideline. Once we confirm the diagnosis or highly suspect the diagnosis, we have to search for the complications. And just for a simplification reasons, we have a local complication, and we have pre-valvular extension of infection, and we have embolic event complications. So let's go to see this thoracic or transesophageal study here. You can see there is something in this point of the basal part of the anterior mitral valve leaflet, and with the color you can see that there is a perforation. The 3D confirmed the presence of the perforation here. So this is a valvular perforation. Another example of no perforation in this time, but you have aneurysmatic dilatation of the basal part of the leaflet, and it was a mycotic aneurysm affecting the mitral valve leaflet. In this clinical scenario, you can see that the bioprosthetic valve is in this place, and here beside the valve there is a sealed cavity which is not respecting the cardiac cycle. It's nothing but abscess, and in this view you can see that that abscess has drained and it creates a pseudoaneurysm in this time. With a color follow-up, you can visualize a fistula. And some type of the complication is very clear for majority of us, which is a rocking motion, very clear for the valve. So we are thinking about the dehiscence. And echocardiography, not only used for catch the diagnosis and assessment of complication, but also to follow up the patient, and also to do it intraoperatively, and also to follow the patient after finishing the course of antibiotics. And it has a lot of strength point, but it has a weakness point, and this weakness point is that it couldn't evaluate the prosthetic valve because of artifacts. It couldn't evaluate the cardiac implantable device also because of artifacts. And we don't know too much about the distant complications. And we need another modality that could cover this aspect of weakness in transesophageal. We have the cardiac CT, and it could tell us about the coronaries, because no one of us want to do coronary angiography for a patient with a big vegetation attached to his aortic valve. We will use the cardiac CT. And cardiac CT could tell us a lot about the area around the valve. You can see that there is a hypoattenuated signal around this tissue valve, which is nothing but abscess, and also the presence of a bucket-like space here, which is the abscess. CT also could tell us about the presence of a fistula, like what happened here. And it could tell us about the vegetations, abscesses, It could also tell us about the distant complications. So here a patient with the lung abscesses, and here a patient with discitis, one of the complication, and here is a picture for a patient with the infarction in his spleen, and this is a lung abscess, and this is a mycotic aneurysm rupture. So the cardiac CT has a complementary rule in patient with infective endocarditis, and it has some weakness point. If the vegetations are small or you have too much artifacts, patient has a complication due to exposure for radiations or exposure to the nephrotoxic contrast. And in order to increase the sensitivity, we need a positron emission tomography. A positron emission tomography could tell us about the metabolic activity of the disease. And if we pay attention for this picture with the positron emission tomography fused with the cardiac CT, you can see that this is the picture here without a positron emission mask, and here with a positron emission mask that shows the presence of heterogeneity of a metabolic active tissue, denotes the presence of infectious etiology. The positron emission tomography has a great role in assessment of bucket abscess, and it shows you how much a bucket abscess here by cardiac CT, but not all of them are inflamed. This one has a big inflammatory process. Here is another heterogeneous metabolic activity by positron emission tomography, and this is another example for a heterogeneous metabolic activity in the pulmonary prosthetic valve. And it's a good motility, but it has low sensitivity for a native valve, for a small vegetations. And as long it fused with the cardiac CT, we have the same complication regarding the cardiac CT. Cardiac WBC SPECT is a nuclear assessment for the migration of radio-labeled white BCs to the inflammatory area, and it play important role, but it considered as a class 2A for situations that the positron emission tomography is not available, with a couple of weakness points. My message is that infective endocarditis is a potential fatal complication or condition. Echo is the first line, and clinical scenario is essential to think about the diagnosis. The other modalities has a complementary role for the diagnosis. And thank you.
Thank you very much, Dr. Sham, for this illustrative talk as usual. My question is about infective endocarditis is a serial condition, and we face many cases, especially after cardiac surgery, prosthetic valve or native cardiac valve. We had severe limitations in our society. TE is not available in all centers. CT, cardiac CT, it's not available in all cardiac. يعني there is multi-use في الcardiac CT, but not as cardiac CT.
Yeah.
Is transthoracic echo لو عملت المريض transthoracic echo وما شفت حاجة واضحة في ال 2D والبريشر gradient across الفالف سواء كان النيتف أو البروستاتيك valve is normal. There is no paravalvular leakage والmean gradient. I see the rocking of movements of the. Is this enough to rule out in our society?
No, unfortunately, no.
You face some cases with these normal features, and the patient had infective endocarditis.
Yeah, it's unfortunately no. If we want to answer this question, we have to remember that infective endocarditis diagnosis is not imaging diagnosis. It's a criteria, and you need to find the bugs. You need in blood, and you need a supporting imaging data. That's the first point. Now, the second point that not all inflammatory process due to infectious etiology form vegetations, particularly in case of prosthetic valve. The tissue around the valve could provide a good media for the bugs to grow up with no vegetation that could be seen in the imaging modalities. That's why we need the positron emission tomography. It tells you that there is activity in the place, and it doesn't tell you that there is a vegetation. That's why transesophageal has a limited role for another reason, which is the artifacts. The prosthetic valve create many reverberations that will block the visual field for the echocardiographer. So you need another additional investigation like cardiac CT if you have a strong evidence like a presence of fever, like a presence of unexplained white BCs increase, like ESR is still high. So you have another additional things makes you think about the diagnosis. I remember a case published in European Society of Cardiology previous year, presented by the Egyptian Society of Cardiology for a lady. She was a 55, post aortic valve replacement, and there is a full stigmata of a peripheral infective endocarditis, but they couldn't find any abnormality on the valve. Later on, they figured that the lesion was a mycotic aneurysm affecting the arch of aorta. So we need a team to solve the puzzle of infective endocarditis. It is not a job for one person.
So our message now, it's not imaging non-modality, it's not, but it's high suspicious of clinical suspicious
sense
for infective endocarditis and treat as...
Exactly.
Thank
exactly.
You. Thank you. If there is any question for Dr. Hisham, for Dr. Abdul Wahab.
Thank you, Dr. Hisham, for elegant talk. My dilemma. My dilemma in the leads regarding device infection. Dr. Hisham. معلش.
I breathe out. I thought I finished there.
خلاص خليك بعيد لما اخلص سؤالي. وين المشكلة؟ من هشام، من هناك المشكلة، من هناك المشكلة مش من عندي. طيب, I will throw my question.
Okay.
My question is about the infective endocarditis suspected in the devices, in the leads. I got with several patients in dilemma whether to extract the device or not. Is there is any infection? If the infection by TE is, vegetation in the TE is clear, so it's an easy question.
I'm sorry, I don't understand the first question. Regarding
the same. It's the same question. I didn't finish the question.
You didn't finish it. Sorry.
Infection related to the devices.
Devices, yes.
Devices, in the leads.
Yes.
If I have vegetation in the leads,
yes,
the problem is always clear. But if I don't have clear vegetation and clear masses in the lead, whether to extract the device or leave it alone. So if I have metabolic PET, it could solve me the puzzle.
Yeah.
But unfortunately, we don't have it,
Yeah.
So what is the best modality here?
For imaging.
For imaging,
Yeah.
And blood culture is almost always negative.
Yeah.
Suppressed by antibiotic used over the counter.
Yeah, I think it's a very insidious question, very tricky, very practical, and the point is the lead is creating a good chance for the bacteria to grow, and that bacteria is completely resistant for the traditional antibiotics, and the only strategy is to remove that lead once you confirm the diagnosis of infective endocarditis. So you need to have a very strong modality to confirm the diagnosis, because this is what affect your strategy in the next step. But the idea is the vegetations developed in the lead are very small. The majority of them are less than 5 millimeter. This has created a big problem with the transesophageal to visualize. Now the second point, that the leads create artifacts with the transesophageal, create artifacts with cardiac CT, so you are not lucky to visualize it. The positron emission tomography itself, which gives you impression about a metabolic activity, if it also could mess cases with the vegetations that are smaller than 5 millimeter, which is a very common in case of the lead infective endocarditis. So it's a very challenge, but I will answer by the same strategy. We just depend on the clinical data in such situations. We don't have one single modality of imaging modalities that could 100% confirm that this is a case of infective endocarditis. Okay, welcome.
Thank you, Dr. Hisham.
Welcome,
my brother, my colleague.
I
have one question about the infective endocarditis of the great vessels. I'm not see any picture here about any vegetation the great vessels.
Yeah.
يعني if there is case either I think 2 cases, one old age and one child with fever for a long time, more than 20 days, maybe 1 month, and no any clear or origin of the source of the fever. And I did for the patient echo, there is an oscillating mass in the root, in the aortic root, or in the ascending. What do you think about this? Is it infective endocarditis?
Yeah. We follow the rules. It's infective endocarditis, and the idea is that transesophageal and transthoracic have a limited field of view on the cardiac valves, and the transesophageal could expand that field of view to the area around the aortic valve, but it cannot see beyond that. That's why we need the cardiac CT. And I think this is if we have a chance later to talk on the break, we can talk about that case published by the Egyptian Society of Echocardiography, because it was a very interesting case. The arch was the source of infective endocarditis in that lady. Yes. Any further questions?
شكرا هشام، شكرا. خلاص. Next speaker. Last presentation for Dr. Omar Abdullah Mbarak Shabibi, consultant intervention radiologist since 2023, and he have also Arab board in diagnostic radiology since 2018. His material is intervention radiology and pericardial effusion and tamponade. تفضل دكتور عمر.
علمين هذا أول، وهذا الإشارة صح. السلام عليكم ورحمة الله. أشكر اللجنة المنظمة وعلى رأسهم الدكتور طيب فضل على إتاحة الفرصة للمشاركة. الشكر للشير بيرسون أستاذي الدكتور عمر باسل، الأستاذي الدكتور أحمد بحاج، أستاذي وصاحب الفضل الكبير علي في هذا التخصص الدكتور عبد الخالق بن نهيد، صاحب اليد الطويلة والفضل الكبير علينا في تعليمنا أساسيات الانترفنشنال راديولوجي، الدكتور والزميل محمد الفلق. تحية للجميع، تحية للضيوف الكرام اللي جايين من كل مكان. أنا سأتكلم اليوم على الرول of interventional radiology in management of cardiac pericardial effusion and tamponade. اقلب ذا ولا لا؟ يا سلمى يا شباب، وين ده؟ من هنا اقلب ولا من هنا؟ Pericardiosynthesis is a procedure done to remove fluid that has built up in the pericardium. الفسيولوجي اماونت اللي موجوده تقريبا في البريكارديال سبيس عاده تتراوح ما بين 20 الى 30 up to 60 ml في النورمال بيرسون. From the first needle pericardiocentesis was performed by France in 1840. Percutaneous drainage of pericardial effusion has evolved from a blind procedure to an ultrasound guide procedure in late 1970. يعني الناس تشتغل الالتراساوند جايد من السبعينات القرن الماضي. Indications and contraindication. Indications large effusion causing tamponade. عادة بيحصل في أصحاب secondary to malignancy, infection or in trauma. Second indication for diagnostic aspiration to detect the etiology. Contraindication, anchor correctable coagulopathy, very small effusion, loculated effusion requiring surgical intervention, aortic dissection or traumatic effusion with myocardial rupture. Pre-procedural preparation, patient assessment. طبعا هذا أصحاب الكارديك يعني ما يحتاج إحنا نتكلم فيه قدامهم. الكلينيكال ساين، التاكيكارديا، هايبوتنشن، بالسس بارودكسس، بيك ستريت،